of human African trypanosomiasis, we can juxtapose it with any other disease that is currently affecting us globally. So control or elimination of disease requires that there are surveillance systems in place to be able to look at the surveillance of people at risk, to see whether the disease is circulating in the community and at what prevalence, to enable informed interventions. Control also entails treatment of people who are sick. So when a disease is in a place, there are treatment measures put in place, treatment protocols on how to identify who has the disease and put them on treatment. And of course, for the human African trypanosomiasis, there's usually follow-up after treatment. The patients are followed up for a particular, almost 3 months, to ensure that their system is cleared of the parasites. And given that trypanosomiasis is a disease that also affects animals, so there's that zoonotic nature of the disease being transmitted from animals to humans, there is need for treatment of animals also, and there have been control measures in terms of acaricides that are used to prevent the animals from getting sick, but there are also drugs that are used for treatment of the animals. Then there's a third aspect, because this involves also the vectors that transmit the parasite to the animals and to the human beings. There is also need to control the tsetse fly. And so there are also measures that have been put in place to control the tsetse fly. Some of them have included use of traps, use of targets to be able to control the fly in specific areas. But traditionally, there was also the aspect of clearing of forests and clearing of bushes around the homes to reduce the places where the tsetse flies can hide. So there have been advancements in techniques for control or elimination of disease, and not just for human African trypanosomiasis, also in the various diseases that we have seen today. So part of the advancements in the technologies entail development of new surveillance or diagnostic tools or techniques, surveillance to be able to monitor the disease, diagnostic tools to be able to diagnose whether people are suffering from the disease. And this is both for human and for animal, the animal component. There's also been development of new tools, especially for human African trypanosomiasis, for determining the stage of the disease. Because with human African trypanosomiasis, it is important that the stage of the disease is determined, whether somebody's in the first stage, when the disease is still just in the blood system, or in the second stage, where the disease has also gone to the brain system, to the blood, has crossed the blood-brain barrier and gone into the brain. So the treatment for those two different stages are different. Hence, the importance of determining at what stage the disease is in. There's also been advancements in drugs, drug development and vaccine development, as we've seen also with COVID. There's been a lot of advancements in development of the vaccines that were used, have been being used in relation to dealing with the COVID-19 pandemic. Similarly, also for human African trypanosomiasis, there have been advancements in the drugs that are used to treat the disease, from drugs that used to be very toxic and would require long-term hospitalization up to 3 or 4 weeks, to drugs that you can even take from your home that are not as toxic as before and can be easily administered. So those are some of the advancements that when we're looking at disease control and even prevention, those are some of the advancements we see happening. And so we have the techniques. We have advanced in our surveillance systems. We have advanced in our treatment regimes. We have advanced in our drug development regimes. But why is it that we still find still find cases of different diseases still rampant in different places. What could be the missing link? So as we unpack what the missing link could be in terms of this complete toolbox that can help us deal with the disease, what are some of the missing links in the implementation, effective and sustainable implementation of this disease prevention control mechanisms? So one of the things we realize is that disease does not occur in a vacuum, and technologies will need to be utilized or administered to members of the community. Hence, there is need for the development of effective pathways of integrating the socio-cultural practices, socio-economic considerations, understanding the social contexts of the communities in which these toolboxes of these techniques will be delivered to enable the successful delivery of the techniques for disease control and elimination. So for us to realize this, the socio-cultural context is a very critical component that we need to understand. So within the missing link, we need to understand that communities are key players in health issues. Hence, public engagement is important in empowering communities to take control of their own health and destinies. Communities are not just consumers of products. They're not just consumers of our techniques and our technologies, but they are also creators of technology. They are also creators of conducive pathways in which these technologies can be delivered. We also need to understand that communities affected by disease are not homogeneous. Hence, one size does not fit all. And it's important to customize our technologies and techniques to the various, and our delivery pathways to the various communities in which we are implementing these activities. So because communities are not homogeneous, if we do not take that into consideration, this may hinder the advances in biomedicine and technology, or even other techniques in addressing issues of disease control or prevention, from translating into results at both the individual, community, and the health systems level. So there are three key areas in which anthropology is relevant for effective public engagement. One of the aspects is that within anthropology, we view populations as biological as well as cultural units, and we study the interactions among ecological systems, health, and human evolution. So key questions that we ask are, how do people in endemic areas or people affected by disease or where there's an outbreak of a disease interact with their environment? How do they perceive the relationship between their ecosystem and disease, or for human African trypanosomiasis? So these are core questions that even when we're looking at disease prevention, there are things we need to know to enable us develop interventions that are appropriate to the community. As anthropologists, we also focus on cultural systems of healing and the cognitive parameters of illness. And so we ask ourselves, how do people define human African trypanosomiasis? How do people define COVID-19? How do people define Ebola? How do they interpret the symptoms of the various diseases? And where do they seek treatment? These are critical questions that even when we are addressing pandemics, when we are addressing outbreak of diseases, there could be diseases which are pandemics, or there are diseases that are endemic in communities. These are important questions to ask to enable us develop holistic interventions. A third key area, as anthropologists, we review interventions, prevention, and policy issues, and analyze the socioeconomic forces and power differentials that influence access to care. And within this, we ask ourselves some certain questions. How do people in endemic areas view and perceive the intervention and prevention programs? We may have the toolbox with these very good innovative technologies and prevention programs, but how do people view these programs? How do they view these interventions? What socioeconomic or political or institutional factors influence their access to human African trypanosomiasis services or disease services? These are key questions that we need to understand in order to deliver, in order for our toolbox of technologies to be effectively delivered into the community. So anthropologists identify and describe the concerns and understandings of disease, looking at the local knowledge, the cause of the disease, the treatment that are relevant to disease control. They also translate local concepts of illness and treatment and the adaptation of biomedical knowledge to fit local etiologies. We may know that disease is caused by a particular pathogen, but communities may have different concepts about what is causing that disease. And as long as we do not understand those local concepts, our interventions with the concept of the disease being caused by pathogens may get, there may be a clash between the two different concepts of illness. And hence it's important to understand so that then we can see how do we navigate to get a midway of this understanding to deliver the interventions that are in place. So anthropologists also translate these local concepts into appropriate health interventions, providing information for education and community strategies for disease control. We also examine the local context of disease diagnosis, treatment, prevention, and the structural as well as conceptual barriers to improve on the health status. We help change how hospitals and primary healthcare services are introduced into communities within the existing cultural, environmental, and social contexts, and also help health workers or policymakers understand the cultural differences in health behavior. Within research, we also prepare ethnographies of health behavior and practices, and these ethnographies can help in tailor-making interventions to suit specific cultural and social cultural contexts. A key example in which this has been applied, there are many examples where this have been applied, but what stands out is Ebola, the West African, the outbreak in West Africa in 2018, where anthropologists were critical towards helping come up with a solution that would help in terms of the burial practices of the community and the burial practices of the public health measures that had been put in place. So by use of anthropologists understanding how the communities view and regard burial practices and the importance of their cultural burial practices to the community, they were able to reach an in-between way of handling the local burial practices in a way that does not expose the rest of the families towards exposure to Ebola. So I'll give a case study of a project that we have been doing that is looking at gender issues and also just understanding the socio-cultural context. So this is a study looking at the gender-inclusive vaccine ecosystem, which was aimed to enhance the distribution and delivery systems for two diseases. One is the Newcastle disease in chicken, and the other one is the contagious caprine pleuropneumonia among goats and sheep. So this is about delivery of vaccines to smallholder farmers. And even as we're looking at the animal vaccine, we find a lot of importance or lessons that we can learn in terms of also the delivery of the human vaccine. So in relation to this case study, livestock plays a very key sociocultural and economic role in many communities and is considered a pathway for women's empowerment. Increased livestock production and equitable decision-making can lead to household food security and dietary diversification, especially in rural areas, which are arid and semi-arid areas. However, optimal productivity of livestock is hindered by preventable livestock diseases, such as the ND and CCPP that are affecting poultry and small ruminants. And uptake and use of vaccines in these areas is hampered by a number of socioeconomic, cultural, technical, structural, and gender-based factors. And so the goal of this project was to enhance the distribution and delivery system for livestock vaccines among smallholder farmers, with the aim of increasing the uptake and adoption of the technique by the smallholder farmers. The key objectives were to increase women's participation in the livestock vaccine distribution and delivery chain, increase their access and adoption of these vaccines, and transform the gender, social, cultural norms and practices to reduce the barriers to women's participation. So this study took a gender analysis. And why is a gender analysis important? A gender analysis is important because it helps us to collect sex disaggregated information. And this information relates along the activity profile of men and women in the community. Who does what are the gender roles, the responsibilities, the priorities of men and women within and outside the household, who owns the resources that exist in the household, who can control those resources. So it also helps to identify the relevant gender issues, the men's and the women's practical needs and strategic interests. Understand the institutional, economic, social, and political contexts. What are the differences in the communities? What are the constraints that men and women face in access to vaccines, in adoption of vaccines? What are the power dynamics that influence, the power dynamics between men and women that influence their uptake and adoption of vaccines? And then understanding the priorities and needs of both men and women. What do they need and what do they want in a disease environment? What are the needs of women when there's an outbreak of a disease? What are the needs of women, of men? And how do we understand this to be able to come up with an appropriate intervention? So we had a theory of change, which was aimed at empowering. We were looking at the things that women own. And one of our entry point was, when it comes to livestock, women own chicken. Chicken is considered a women's livestock. And so one of the things we wanted to do was to empower the women so that they cannot, instead of just having a few chicken, they can move up the economic ladder and own more chicken, own more, own even sheep and goats, by improving the productivity of their chicken, accessing vaccinations, and utilizing the vaccinations to be able to improve on their productivity. And all this is with the aim of improving the household nutrition and the household health. And so we had different interventions to help deal with this aspect. One of them was to form cooperatives or groups, the power of groups, so that women can be in groups and leverage on access to vaccines as a group. We had trainings to expose them to information about animal husbandry practices. And this was not just for women, we also brought in the men, because we realized that men are critical components. Even when you're working with women, you cannot leave the men behind. And we also intervened by providing vaccinations. And so we also worked with people from the veterinary vets who are able to help in terms of the animal husbandry practices. We worked with people from the cooperative department who are critical in terms of addressing the power of collectives and how communities can form collectives that can help them access resources. And then also we worked with the community, with the gender experts and the nutrition experts to just help provide information on nutrition and also provide information on gender issues and create dialogue in the community to help them deal with the social and gender norms that exist in the community in terms of ownership of animals. So just a summary of the findings, we found that chicken rearing is an economic activity for women within the study area, which is Makueni in Kenya. We found that more women than men own and participate in day-to-day control and management of chicken and sheep and goats activities. And we found that women prioritize the household welfare when they get proceeds from the sale of their chicken, as opposed to their male counterparts in their households. Some of the challenges that we found the community faces is there's a high disease burden, and the community over-rely on herbal remedies for treatment of animal diseases. Their lack of markets for selling their products. So even as we are working with the women, it's important in terms of dealing with the aspects of marketing so that both men and women are able to sell their products in the market for them to be able to get something out of that, the increased productivity of their livestock. And we found differences in terms of access to markets, differences in women and men's access to markets. And then there was limited knowledge, especially among the women, in terms of animal husbandry practices. And this is as a result of their low literacy levels. Our study also showed that cultural barriers and norms hinder women from engaging and participating in poultry production and vaccination. And this is as a result of inequitable power relations and access to resources that maybe tend to favor men more. Then there's the power shifts when there's the aspect of commercialization when the productivity increases, men now want to take over the control of the benefits, and hence there's need to see how to address this. Then there was also limited access to long-term training on good husbandry practices. Men would be able to attend the meetings more as opposed to women, because women have other roles they play in the home, and sometimes they have to ask for permission from the men to be able to attend some of these meetings. And also the difficulty of balancing domestic chores and other engagements. And so these are some of the cultural barriers that hindered women from participating in this livestock vaccine value chain and engagement in the vaccine access and knowledge. There were also challenges in terms of access to credit facilities for the financial needs that were required to be able to access the inputs for the livestock farming. And then we also found that there are trainings in terms of improving capacity program by various organizations and non-governmental organizations, governments. But what we saw is that there is no follow-up or refresher training of the community. So what we realize is that even when information or training is done in a community to pass information, there's need for consistent training, or at not just a one-off training, but it has to be a continuous training to enable the information sustained in the community. Some of the observed outcomes as a result of this study was that we saw changes in norms. Men are increasingly joining and participating in the groups that entail the poultry groups, which initially were just women. Mainly it's women who are part of these cooperatives or collectives, but we saw men increasingly joining as they came to understand the power of them working together. Women are also taking up leadership positions, and there's increased male support and facilitation. For the case of this community, we worked with what we call the community vaccinators. So we trained some members of the community who are identified by the community in terms of providing education to the community, peer education to the community, and providing kind of the first level of advice to the community in relation to dealing with animal diseases. And so we found women taking up these positions and also being supported by their spouses, and women were able to engage in the vaccination of chicken and provide information to their fellow women. And this was well received. Information was, they were able to pass information even in areas where the mainstream information sometimes does not reach. Some of these areas are inaccessible. Then the power of collectives, we found farmers increasingly selling their chicken collectively as a group, and that means more money coming to the community. And so within aspects of diet, because our goal was to improve on the diet, the nutrition status of the community, we found that the community were incorporating now more of the animal source foods in their meals compared to when we started the study. And so we see this as a component of improving the nutrition of the community. And we know that also with improved nutrition, then there's also improved health and improved immunity, which can help deal or prevent diseases. So in specific reference to this study, we recommend that the strengthening of smallholder farmers, especially women's voices and agency in dealing with aspects of vaccine or in dealing with aspects of disease control. We also recommended initiating dialogues and processes that are aimed at addressing gender and social norms, because gender and social norms are things that cannot be changed overnight. There is the need to initiate dialogues with the community, and having these dialogues will help bring about some change and understanding in the community. Initiating dialogues on aspects of disease risk, because one of the things we also realized is that what we see as a risk in relation to disease is not what the community sees as a risk. So there's need for continuous dialogue on disease risk communication with the communities, and the inclusion of men in programs that promote women empowerment for increased uptake, and using locally acceptable channels to deliver information and technologies has a high chance of improving on acceptance of these technologies at the community level. So going back to our toolbox and the missing link, what are some of the considerations or the take-homes that we can have in mind even as we're dealing with disease control? One of the aspects is that the contextual aspect is very important. Just as we said as we were beginning, that disease does not occur in a vacuum. It's important that we understand the socio-historical and political contexts in which disease is occurring and in which interventions are being implemented, because perceptions of past interventions influence control strategies, and lack of trust between governments, health workers, control programs, and communities can be impacted on by these contextual aspects that, if we do not take into consideration, may derail public health interventions. The other aspect is also the political economy, the power play and the dynamics that exists within in implementation of disease interventions at a local level, at a national level, at a regional level, at a global level. We need to take into consideration the inequalities and the vulnerabilities that exist, so that even as we are providing interventions, our interventions will be inclusive of all the different aspects and the different categories of groups within the communities. Other points for consideration is that socio-cultural and gender dynamics play a key role in increasing or reducing vulnerability to disease. Identifying community indigenous knowledge is important because, as we said, communities are not just consumers of our technologies, but they are also creators of technology. They are also the custodians of indigenous technology and indigenous knowledge, and hence there is need for co-creation of interventions with the communities, so that it's not a top-down approach, but it's a co-creation approach that involves the communities in providing direction in how disease is managed. So inequalities, there's need to also identify the inequalities and vulnerable groups within affected communities, as well as the sources of resilience that exist within these communities so that we can build upon them. The formal responses can build upon what is already existing without forming parallel responses or parallel interventions. Yet there's already existing interventions that we can build upon for successful intervention delivery. Anthropology is also important in assessing, monitoring, and addressing the socio-cultural context and inequalities, in also assessing the inequalities and the vulnerabilities that may exist in prevention, preparedness, and response to diseases. So as I conclude, I would say that there's cooperation between anthropologists, the biomedical scientists, the environmentalists, healthcare workers, policymakers can lead to effective ways of engaging the community in more appropriate and effective ways, hence improving the quality of life and finding long-term solutions to local health problems. The need of working together is important. So given the holistic aspect of anthropology, that anthropology intersects on the aspects of human relations with their fellow human beings. Anthropologists study human relations with their animals. Anthropologists also study the human relations with the environment. There's need to incorporate anthropology and also the social sciences when it comes to management, disease prevention, disease preparedness, and disease response, because we cannot address disease without putting humans at the center of disease prevention, disease preparedness, and disease response and control. So thank you. That marks the end of my presentation.
Thank you very much, Professor Pukache, for that. It's always important. This is from an anthropological, view perspective in terms of what we are looking at, especially with the neglected tropical disease. And I always say Africa is rich in its ethnicity, but at the same time, we ignore when we put our control measures that each community has got different norms, and only anthropologists can actually work with them better than the biologists. Questions, comments from what has been presented by Professor Pukache? Yes, we have got several hands up, maybe someone to help us with the mic. We've got Professor Chimbare and then from the back. Okay.
Excellent presentation, Salome. It's always nice, as Samuel said, to listen to the other perspective of people who really care about people. My question is probably going to deviate you slightly from your presentation, but I like to hear your insights on, the vulnerable groups that you talk about and the issue of empowering women. What has been your observation in your research career with regards the women you were talking about and the women who are sitting in this room? Because I'm saying this because sometimes I felt that because we adopt a lot of information that comes from the West, we are on a journey sometimes to actually disempower our rural women who have always ruled from the back. So I just want to hear what would be your approach with the women sitting in this room vis-a-vis the women in the rural area?
My question is with regards to the knowledge and the views of the communities that Prof highlighted as important in the management or control of diseases. Just want to ask, are there any indigenous knowledge or approaches that you have found effective in disease management and control over the years of your research work? As an, are there those indigenous approaches that are still effective in disease control or management?
You may proceed to answer, Prof.
Okay. Yeah, so thank you very much for your questions. I will start with the last question on knowledge and the indigenous approaches in various communities. Yes, we have come across various communities that use indigenous approaches to dealing with disease control. And a lot of it, the one that I have come across is the use of herbal medicine. And this I've seen in among the pastoral communities who have indigenous ways of identifying even, for example, if an animal has died and they want to know whether this animal is died of a disease that is not good for them to consume the meat, they have a way among the communities in the Rift Valley. They have a particular ant that they use to identify. There are some ants they use to identify. So they cut a piece of the meat and put it somewhere where those ants are. If the ants go towards the animal, they will know that this meat is okay. If the animals go away, they know that that meat is not good for consumption. And so these are just some of the aspects. Then they also have a lot of herbal, either there's some leaves or some branches that they know that help to deal with some of the both animal and human disease. So that exists. I think the aspect is just taking that forward to a way where that can be, maybe more research can be done to pull out, to find out what is the chemical within this that is helping. But yes, these lots of community indigenous knowledge in relation to management of both human and animal health. We also came across communities who have been able to look at different things to foretell weather forecasting. They have the indigenous practices on how they foretell the weather forecasting. And so that's also something that is important just to look at and see how does that relate with what our weather forecasting for today is. So moving to the first question on the difference between the women who are sitting in this room and the women who are sitting out there. I would say that when I look at the women sitting in this room, and I'd like to speak on behalf of the women researchers or the women scientists, there's need for us to also take this into consideration. When we look at research and we look at the outputs within research, the differences between men and women, we find that there's been things, or maybe let me talk about them like strategic needs, differences between men and women, and practical needs that make women sometimes lag behind in their science or in their research or in their work. A man may be easily pick up maybe a training and go for further training. The woman has to think around, I have a household. How do I go? I can't just leave the children. It may be easier to support the man to go than to support the women to go. But increasingly, we are saying we want to see more women sitting on the table. How can we come up with strategies that can help them take care of their other roles, even as they participate in production of research or within the academic sphere? And maybe I'll throw this back to you, Prof. Chimbari, even for the women seated here, sometimes even just accessing the resources to attend. Or maybe there's somebody who has a woman who has a very nice abstract or presentation they would need to make. But when we find them when we find the funding, maybe we are supporting them to attend conferences, we do not take into consideration that at the side of their lives. And so I would like to see, maybe as we move ahead, scholarships that also can allow me as a woman to come with my small child to attend this meeting so that I do not miss out on such meetings. Scholarships that can enable me carry my child and go with them where I need to be, so that then I do not lag behind, but we move together at the same pace. So these aspects of empowerment exist both at the local level and at the scientific field. It's just that we need to address them, identify them and address them. I hope that addresses the question.
Okay, thank you very much. Any other comments, questions? We've got several from Professor Mafongwe, then we come to.
Thank you, Prof. My question is about indigenous knowledge. How are you documenting it? It's one thing to observe it and leave it there, and it goes with the knowledge holders. Are you documenting it, and are you trying to integrate it with what is quoted scientific knowledge, so that we see the synergy of these two?
Yeah. Let me.
Morning, Prof. I don't know whether you're answering or should I proceed to ask my question.
Just proceed then.
My question. Okay, my question isn't too far from the last question that has just been posed. You referred to one of the challenges being an over-reliance on herbal treatments of the livestock. By herbal, what are you referring to? Are you referring to traditional treatments, or is there another definition of herbal treatments? And then I'd like to ask, is there also a challenge with an over-reliance of the use of westernized medication for the treatment of livestock? And the reason I ask that is that maybe this is a little deviation from your presentation, is that we're always hearing about the challenges relating to people overusing traditional medication, which are related or advertised as being toxic for human beings because they're not scientifically tested. Yet we don't hear or the dangers of Western medications aren't particularly communicated with people. However, we see the same dangers. So I just wanted to find out that when you're talking about an over-reliance of herbal treatment being a challenge, is that challenge also within Western medication? Thank you.
All right, thank you. I'll address those two. The first one is in terms of how are we documenting this information, and are we integrating it within the other formal science methods? I think maybe I'd say that this has been one of the challenges in terms of how to document some of this indigenous knowledge that we come across. When we did our study and identified various herbs, roots, leaves, parts of the trees and plants that the community we were working with identified as some of the diseases, the plants that they use to treat various ailments. We tried to work it out and present it at a different place. So one of the things we were asked to do was to pick samples of these leaves and roots and present them where they could be then to help identify the scientific needs. So we did that. We collected some of those plants, which we pressed them, And we presented them to the national museums to help us identify which plants this belonged to. But unfortunately, we were told the way we had preserved the plants, we didn't do it so well. And so they were not able to work with what we had already collected. The second stage we tried is to try and look for just then the scientific names of these plants to relate to which plant this is, and to do a paper that would help bring out this indigenous knowledge or share this indigenous knowledge with other communities. But again, we hit a snag when it was a challenge for that paper to be accepted. So I agree. I agree, and we are open towards learning ways in which we can document and learning ways in which this indigenous knowledge can be contained and documented for posterity. The second question on the over-reliance on herbal medicine. Excuse me. I think your question is, excuse me, your question is a very good question, because sometimes we do not balance the aspects of the herbal medicine and the use of the conventional medicine. And I agree with you that there's a big challenge right now, even when we look at the issue of AMR, the antimicrobial resistance that is common right now, is as a result of, I would say, also over-reliance or misuse and overuse of conventional medicine that have antibiotics. When we look at the pesticides and the acaricides that we use on our crops, on our livestock, and even on the humans, there's that aspect of the overuse, and hence that can also be a challenge when it comes to dealing with disease control. When I talked about over-reliance on the herbal treatment for the case study that I gave, yes, it's there's a lot of use of the herbal treatments, but maybe how we report it maybe should change. What we meant was that the community uses there's herbal treatment they use which is good and which works, but sometimes you find them using other things which are not, using some herbs which are not so good for their livestock. And so there's need to be able to also just have some training on which are the good practices in relation to the herbal treatments that the farmers can utilize, which are easily available in the environment for use without using the wrong herbal medication for the treatment. So I think I can say that in both ways, there's need for us to see how to address the issues of over-reliance even within the conventional medicine that exists, and that creates also challenges in disease control.
Okay, thank you. Yeah, just one comment or question. When you talked about the human African trypanosomiasis, on the control of the tsetse fly, I remember some years back, maybe more than 20 years ago, the technologies which was discovered in the last 30 years are really effective using the targets, which means they've got a cloth which they put with a certain color, attracts tsetse flies, very environmentally friendly. So I led a project which involved Malawi, Zimbabwe, Tanzania, Uganda, and we had a very interesting encounter in Malawi where we put a lot of targets, this cloth, in the bushes and whatever. 3 months when we came back, there was nothing. All the cloth had disappeared, the targets and whatever. And when we went to the chief to ask, they say they didn't know what was happening. And then there was like a search of what happened to the cloth. Then when they investigated, it came to an old man, who had his homestead. He was the one collecting everything, in his house, and he was making school uniforms, nice ones. But this is how in a community, if you don't interact with them, they don't see the reason why you are putting all those things. And the first approach was this old man should be arrested. Look, that's even the worst. He was a very poor old man. He found a source, you know, he had a sewing machine where he used for uniforms. So it just shows us that we are not interacting with this community. We are just seeing them as objects, which we can go and do our things and whatever. But one question, are we in shortage of anthropologists in Africa? Because I rarely see anthropologists even volunteering to work with us in our, I don't know what mainly anthropologists do in Africa, but I've seen a lot of anthropologists from Europe or from any other parts wanting to come and work with our communities. I don't know for what benefit, because we should be working with our communities and understanding our communities. So I just want to ask if anyone, if I have got a relative or whatever who wants to be an anthropologist, what would I tell them? What are the perspectives, especially in this area? Thank you.
Thank you, Prof. Yes, I would say that anthropology, I would talk about Kenya. We have students who come to study anthropology, but it seems it's not quite known. So you find the parents telling them, what is this anthropology you're going to study? Go and do teaching, change and do a BA course, a BA general course, because they don't understand anthropology. And so we find that the concept of anthropology has not been quite well understood. And so we have recently formed an association of anthropology, Association of Anthropologists in Kenya, which is open up also to other anthropologists within the region, for us to help champion what anthropology stands for, because I believe we hold a very critical point when it comes to aspects of community engagement. So we are already doing that to help just advocate for what anthropology is. So I think because of that, there have not been so many anthropologists. They are there, but maybe also the interest, the different, because anthropology has different components. You can either be within the social anthropology, there is the archaeological anthropologists, there is the linguistic anthropologists, and there is the biological anthropologists. So people take different ways, can specialize in those different aspects. A lot of what I see is anthropology of African studies. And so you'll find them at a different level. Maybe there'll be anthropologists looking at African studies at another level. So I think based on that, the study of different things within anthropology, then you find that maybe when you're looking within the medical, the health perspective, then there are few of them. But we are working towards collating all of them. And I'd be interested to also interact. I know there are some anthropologists, medical anthropologists in South Africa, and even in this meeting, I would like to interact with the medical anthropologists across the continent, so that we can also become a cohesive unit and see how we can also champion our own issues forward. Because when we have our voice, then also our knowledge, our indigenous knowledge can also be, we can project it out there for others to also get to know it. And then we'll find ourselves also being the ones who are researching among ourselves and not always having to depend on others.
Yes.
Yeah.
Thank you so much for that. And okay, we have another question and then another one here.
Professor, I want to just give a few examples of documenting what I meant by that. This is the problem with people who work with the proof of the concept is there, the chemical works. But what I'm talking about is documenting it in books, in videos, in archives, because what we see in indigenous knowledge is that the young people, there's some dissonance which is coming up to say, the old people used to say this, but they're not very accurate about it. So even introducing into curriculum from secondary school, primary school, up to university, so that the indigenous knowledge perpetuates. So we published a book about 4 years ago on indigenous knowledge and climate change management. We did examples from Nigeria up to Kenya, Uganda, Southern Africa, and so on. And a lot of people are using this book, and the information is documented so that if the holders of that knowledge pass away, at least we know what it is. But just saying we need to know the chemical, what is the polyphenol, whatever it is, it's a step down the road. That's not the most important thing. But we need to document this knowledge before it disappears with the knowledge holders. And there are various ways of documenting it and archiving this knowledge.
Thank you.
Very much.
Thank you.
Yeah, there's no more. Okay.
Thank you, Prof, for that nice presentation. So I just wanted to ask, with relation to the, the plans or that you have in maybe in your country, like, are there sort of any coordinated efforts among, let's say, yourselves as anthropologists and maybe even entomologists and other parasitologists and other people that can be involved in tackling this problem? Or are you sort of approaching it as isolated research projects where, let's say, from an anthropological side, you have your sort of research questions or objectives where you try and answer them and then that's it? Or do you have, I don't know, a committee or just any coordinated efforts among different disciplines to try and tackle this problem?
Thank you. A lot of times, and maybe giving a case study of the human African trypanosomiasis control, we had a coordinated aspect of handling it. I would say we'd handle it from that One Health approach, where we had the entomologists, we had the veterinary personnel, we had the social scientists, we had the primatologists, we had the people who deal with the drug development and drug testing. So we'd work as a team. We'd go to the field and collect data as a team, develop the objectives together, and go and carry out research together. So that's within the human African trypanosomiasis control space. But also within the control of other diseases or research on other diseases, we work a lot together. Like now in Kenya, we have what we call the Zoonotic Disease Unit, which brings together expertise from the Ministry of Health, the Ministry of Livestock, and also bringing in the new, one of the gaps has been the Ministry of Environment has been a loose link, but now there's that effort moved towards bringing in also the Ministry of Environment in having a national level unit that is able to address issues of disease from a One Health perspective. But just also the research we do at the university, we don't just work alone as anthropologists, we combine with other departments within the university or also other research institutions to address the issues of disease and even aspects of development together as a group.
Okay, thank you. It looks like there are no further questions even from people online. So once again, Professor Bukaja, I thank you for this presentation, which has attracted a lot of discussions. And I think it's also from a different perspective of how we've been looking at these diseases, which are in sub-Saharan Africa. If there are no further questions, I think it brings us to the end of this first session. And yeah, we'll break for coffee, I think. And for those online, I think you might as well break. I wish we could share our coffee with you, but it's impossible. So thank you very much, all of you, for your participation in this session. Thank you. I don't know if there are any housekeeping issues which we need to, but I think it's coffee time now. Thank you. Is it at 11? So, okay. Okay, for those online, I don't know where you are, but we will commence 30 minutes from now. So it's around 10 to 11, well, it's around 10 to the hour. So which means we will be reconvening around 20 past the next hour. Thank you.
To all our online viewers, the next session will be commencing at 11 South African time. That is 11 a.m.
Hello, can you hear me?
Hello, Jacob.
Hi,
Yeah.
Jacob.
Hi, Margot.
Hi,
there.
Margot.
Oh, look at
Hey,
that.
Kerry.
Carrie.
How wonderful. Wonderful to see you all.
Indeed it is. Fabulous.
I
What a treat.
just grab a coffee.
Can't hear you.
How are you doing, Pierre? You've just finished your retreat?
I've just taken a 1 hour, I've excused myself for 1 hour. It's
Okay.
and the retreats are funny things. I'm actually sick of the sound of my own voice, so I'm going to have to deal with that.
I'm not sure if we're broadcasting into the whole room here. So
well.
just to
Yeah.
look, it's so wonderful to see you all. But Kerry, where are you? You're home amidst your trails? Oh, you're not hearing us.
Doesn't sound like it, does it?
No.
Maybe you have to send her a message.
We are.
Just-
I'm sending her a message in the chat. Might just be a settings thing. So the previous session.
Can you hear me if I talk like this?
Yeah, we
Got it.
can.
You can hear me fine. I just can't hear you for whatever reason. I'm just trying to sort that out.
Okay.
Oh, okay.
Yeah.
So Jacob, the previous session just finished about 15 minutes ago, and they said they were going to be starting back around about now, but I think they haven't been on a break for very long. Oh, there we go.
Hello, testing, 1 2 1 2.
We can hear you.
And we can see Moses. Is that Moses?
No, it is Moses. Yes, there's Moses.
My apology.
Okay.
My apology about the previous communication. I will just start the session now.
Speak was fine. Test. And test. Your device is not.
Good morning, colleagues. Can you hear me? Good morning, good afternoon, good evening to some people who are on the Zoom platform. Can you hear me?
We can hear you, Moses.
Okay. My apology about the communication just a few minutes ago. We were in a session which was running late. And so we had wanted to give people 30 minutes tea break. But then I realized that it was serious negotiation to get the past presidents together on one platform because they are all in different time zones. So we've had to ask people to come back to the plenary session so that we can have this session. So in just a minute, I'll formally start this session. So this session has been designed to last for 1 hour. So we hope we can manage that and spill a little bit by a few minutes so that we stay within our time. It is my honor to chair this very important session, probably the most important session of this conference. Important in the sense that we are bringing together on one table past presidents of the association, which has been in existence for a very long time, from way back 2003, 2006. It is not easy. We know that in America, it's quite easy to pull past presidents and bring them to one table. And I see South Africa is doing the same thing quite often. So we feel very privileged to have been able to convince them to come to this session. This session is about looking at the synergies of One Health, Ecohealth, and planetary health. We know that our past presidents, some of them have moved on, they've become experts in One Health, some of them have become experts in planetary health, some of them are cutting across. So we would like really to hear from them, having led this association, which is transformed to become Ecohealth International after having been in association of ecology and health for some time. So this discussion will take a format of a panel discussion where I will be able to ask them the same question and give them a few minutes to summarize what the synergies are, and perhaps we'll be able to have another round as well. So before I start, I would like really to just tell you who they are in no particular order. So I'll start off with
recording in progress.
Kerry Anabila, who actually handed over the baton to me as I became the interim president of Ecohealth International. Kerry is a descendant of the Meriam people from the Torres Strait. Her work has brought her to the forefront of indigenous affairs in Australia. A former social worker with a doctorate in environmental science, Kerry has held senior positions, including Chair of Indigenous Health at the University of Melbourne, Executive Director of the first 1000 Days Australia, CEO of the Luija Institute and Director of Indigenous Health Research at Monash University. Internationally, Kerry has held senior positions with Ecohealth International, consulted for the World Health Organization, and completed a fellow program with the Rockefeller Foundation. With an extensive background in public health, administration, community development, and research, Kerry has led a wide range of organizations and communities. Currently, a director of Kinaway Chamber of Commerce and Ignite, Kerry holds an honorary professorial position with the University of Melbourne, manages consulting, publishing, and coaching companies, and has several entrepreneurial programs in development. Please help me welcome Professor Kerry Anabila to this platform. You are welcome, Kerry. We also have got on the platform here, Jacob Zinstag, who also would have handed over the baton to Kerry. So Jacob is a veterinarian with a PhD in tropical animal health. He spent 8 years in West Africa at the International Trepano Tolerance Center in the Gambia, and 4 years as the director of the Center Suisse de Rechos, my apology for that, French, in Cote d'Ivoire. Since 1998, he has been heading a research group on human and animal health at the Swiss Tropical and Public Health Institute. Since 2011, he has been the deputy head of Department of Epidemiology and Public Health at Swiss TPH. He focuses on the control of zoonosis in developing countries and the provision of health care to pastoralists using the One Health approach. He is a past president of the International Association for Ecology and Health, which is now Ecohealth International, and is a former president of the scientific board of the Transdisciplinary Network of the Swiss Academies. He is an editor-in-chief of CABI One Health Resources. Welcome to the platform, Jakob, and please help me to welcome him.
Hello, everybody.
We also have got on the panel Pierre Holwitz, who is a professor of environmental sciences at Edith Cowan University, Western Australia, and co-director of the university's Strategic Research Center for People, Place, and Planet. He has research interests and expertise in the links between ecosystems, biodiversity, health, and sustainability in sustainable water resources management, with research projects based in Australia, Southeast Asia, and Oceania. He was the theme coordinator for wetlands and health for the Ramsar Convention on Wetlands 2009 to 2015, and is currently the co-editor-in-chief of the journal PLOS Water. Pierre has received awards for postgraduate supervision, having seen to completion 48 PhD and masters by research students, and performing as an external examiner for around the same number. In 2003, he helped found what was then called the International Association for Ecology and Health, also known as Ecohealth, and was the founding vice president for nearly 5 years until 2008. So actually, in terms of the association, in terms of being a president for a long time, he's actually the one who is the longest serving member in the association, because he was there from its beginning. Then I want to move on to the next one. So before I do that, please let's welcome Pierre to this forum. Welcome,
Hello,
our
everyone.
Vice President and
Thank
our
you.
great mentor on the eco-health issues. I want to introduce also Margot, who is now a very familiar face after she didn't sleep for 24 hours, just from Sunday to Monday, our local time here. Margot is a professor in the UNBC School of Health Sciences, past Canada Research Chair in Health Ecosystems and Society, and current co-lead of the UNBC Health Research Institute, with 3 decades of learning from eco-social approaches to public health. Dr. Margot Park's research connects social and ecological determinants of health, especially in rural, remote, and indigenous communities, drawing on a background in medicine, public health, human ecology, and eco-health, and collaborations spanning New Zealand, Oceania, Europe, and the Americas. In all her work, Margot prioritizes working and learning with others across regions, cultural contexts, disciplines, and sectors. Her work seeks to foster better understanding of land, water, and living systems, the ecosystems, as foundational for health, equity, and well-being, and to strengthen collaborations that reflect these connections and foster capacity for integrative approaches to research, education, and practice that address health, environment, and equity concerns. Margot is a strong history of partnered research involving health authorities, watershed organizations, non-for-profit groups, and indigenous-led organizations, especially in rural and remote contexts. Dr. Parks is active in regional, provincial, national, and international collaborators. Current examples include a role as a founding co-lead of the Canadian Community of Practice in Ecosystem Approaches to Health, a co-lead of Pan-Canadian and internationally partnered as co-chair of the EDGE. So she has actually been all over. And I just want to say, reading this resume, you don't see a doctor anymore. I haven't met a doctor who has got a profile like this. Probably the only one who matches what she has got is Dr. Dlamini, whom I counted to have something like 6 masters and 2 PhDs. Welcome, Margot, to this forum. Colleagues, with that, we want to start moving into the session. As I said, this session is around our conference theme, which is about healthy, just, and sustainable planet Earth that we want to see and make sure that it continues for the next generation. So what I'm going to do is to ask the panelists to briefly tell us what their synergies are in about 5 minutes or so, what they see as synergies for between One Health, Ecohealth, and planetary health. And I didn't warn them ahead of time, so I hope that it's okay with them if I can start with anyone, and so that I'm not biased. I see my friend Kerry seems to be on top of the list as number 1. So Kerry, take it away, please.
Nyonyo, thank you. Oh, wait a minute.
Can you unmute yourself, please? You are still muted.
Moses, because Kerry's come in on her phone, she's getting a bit of feedback. So she said, "Can you go to someone else first, and she'll figure out the details."
Are you able to unmute her?
I think I'm unmuted. No, it's not working. Wait a minute.
Okay, so that we sort out that glitch, I probably should move on to Jakob for now. Yep. And we'll come back to Kerry later.
Okay, can you hear me?
Yes.
You know, I started off myself with working on One Health, and we defined One Health as the added value or incremental benefit of a closer cooperation of human and animal health and related sciences. And then I went on sabbatical to Guelph in Canada, and I met David Waldner-Taves and Margot, and they introduced me to Ecohealth. And then conceptually, I understood that One Health is embedded in Ecohealth. So that was my understanding. But then 2011, we had the Ecohealth conference in Melbourne, and then our dear colleagues Ab Osterhaus and John Mackenzie and came and organized a One Health conference in parallel. And I was in disagreement with them because I told them One Health is part of Ecohealth. But in the meantime, One Health has really gained footage. And today, One Health is actually the best operationalized integrated One Health concept. And it is adopted by almost all many countries who build up One Health platforms. That's the reality. And I just come back yesterday from Singapore on the 7th International One Health Conference with 2,500 delegates, part of them online, of course. But One Health has really gained foot. But for me, it is still embedded in Ecohealth. That's the situation. And now planetary health. Planetary health is something very strange. It has no clear definition. But in the Lancet One Health report, planetary health report, animal health and veterinary medicine don't even figure. So my position is that planetary health is a completely anthropocentric concept that does not consider animal health. So I would say One Health is still the best operational concept worldwide at the moment. But for me, it is still completely embedded into Ecohealth. In 2011, in Durban, I was invited to the conference of veterinary epidemiology and economics. And there I brought in the concept of Elinor Ostrom on social ecological systems. And I coined the term health in social ecological systems, which includes the economy of natural resource management. So I would say this goes a little bit further than the classical eco-health concept, but still, I would say eco-health is really, for me, the overall embracing concept that we should follow. But politically, One Health is much better operationalized at the moment. That's my assessment of the situation.
Thank you very much, Jakob, coming in and saying that, he doesn't see much separation between Ecohealth and One Health, except that One Health is a way of operationalizing aspects of Ecohealth. Completely saying that planetary health is anthropocentric and disregards some of the aspects that are crucial. Let's move on to Pierre.
Kaya, I'm coming from Wajak Nyunga Buja on the lands of the unceded country of the Wajak people in the southwestern corner of the Australian continent and the Australasian plate. And so on the other side of the Indian Ocean to you, and I'm sending greetings as I wave. I see One Health, Ecohealth, and planetary health somewhat differently. In some ways, I see them as having an enormous area of overlap. I think that there's a Venn diagram with a very large synergy, and I think that synergy is characterized by a critical focus on human health, an involvement of and a necessary involvement of ecosystems and environmental determinants of health, as well as social determinants of health. I think all three, but in that, I think that there are differences. And when I think about the differences, it's I see it as a paradox between about whether these differences are sufficiently large that they constitute paradigmatic differences, or whether they're so small that they're like the different flavors of the same ice cream. And I don't, and I sometimes I think that they are paradigmatically different. And the judge of whether they're paradigmatically different, in other words, involve really quite different thinking, is whether they if one were to be adopted in the future, looking back, would either of the other two be incommensurately different? So would we not be able to recognize the value of either of the other two? And at the moment, I don't think that's the case. So I don't think that this is a paradigmatic difference. I think that the overlaps are sufficiently large. My plea then is for us to recognize the diversity that comes with the three. And that diversity is added to another plea of mine, which is to recognize that in human health terms and in terms of the health sector, these three mechanisms all give us an ability to bring ecology into the equation, to foreground ecology. And they also bring into that equation the ability for us to recognize the importance of the local and the importance of place-based approaches. So those three things allow us to develop other types of thinking, whether it's anthropocentric or not. I don't think that matters. I think what matters is that we allow knowledges that recognize that we are related and we're related to our surroundings. And I know that there's a very strong body of work that's emerging now from our Indigenous colleagues to help us guide, to be guided in that way of thinking. And that so developing those relational values means that we can challenge some of the underlying features of other approaches to dealing with human health. So my summary then is, let's not try to reconcile the differences between the three. Let's recognize the synergies, applaud the synergies, and then let's allow ecological and relational values to emerge so that we know where we are placed in the systems that we're trying to deal with. Thank you.
Thank you, Thierry. Coming very strong to say that the three bring a necessary diversity, and actually saying that there is some complementarity which we should not, just underwrite. So let's move on to Margot.
Thanks, folks. I hope you can hear me okay. I wanted to begin with a real appreciation for the hosts for convening this conference. We know it's been a long journey, and Moses, congratulations for convening this panel and bringing in a sense of kind of history and different perspectives. I do want to just touch on the theme that I really want to bring in today. I think it resonates very well with what Jakob and Pierre just said. And for me, I begin with the eco and Ecohealth, which is that if we go back to the roots of that word, it is, of course, the same root in the word of economy. It's the same word in ecology. It's the same word in ecosystems. And in all those words, it means its origins mean our home. And one of the things that I think is so important as we explore the synergies between these fields is to recognize the planet is our home and also the nested systems that we live within. And so Jakob was making the case that we are embedded, that different things are embedded in different ways. And so for each of you right now, I want you to just take a moment looking to the bottom of this diagram and recognize that for so many of the creatures or humans and otherwise that we're thinking about, we've got the same patterns of life that is in our bronchial trees and our arterial trees. It's the same patterns of life and the fungal hyphae that create the food systems that we live on, the cracks in the ice, the branches of trees, the braids of rivers, the branches of deltas, and all the way through to this fundamental relationship with our living systems. And that in that regard, I find it very helpful to recognize that when we are talking about One Health, of animals and humans and all our relations, as many people from the territories that I live in and Northern British Columbia would refer to, and many of the influences on my own thinking, recognizing the depth of connections between humans and other species, that I've been fortunate. I'm calling in today from near Tamaki Makaurau and Aotearoa, New Zealand, and the Maori of these territories are always making these references to see the connections. So for me, that's the important message, is that if we think about caring for our planetary home as our home, rather than as a source of hazards, whether those are microbiological hazards or contaminants, that if we think about these places as our home, that it invokes the necessary care for us. And so I'm really interested in work, whether it's Ecohealth, One Health, or Planetary Health, that is founded on a caring relationship, and that research is underscoring the need for us to care for our shared home, and that is founded on connections, and it's founded on the confluence of ideas. The other thing I just would really like to emphasize in this is just to, as Moses mentioned, we spent 24 hours together walking around the planet in this pre-conference event. It was a very powerful experience to spend. On the left-hand side, you'll sort of see the 5 regions we walked through. And some of the characteristics that I think do bind these fields, but I think Ecohealth does particularly well, is to celebrate its early career colleagues. And I really want to acknowledge that it's in that next generation of innovation and connection. For many of our early career colleagues, the distinction is actually becoming unhelpful. And that what people are doing is finding their place in the diversity that Pierre mentioned. They're recognizing there's a bit of redundancy sometimes between these fields, but they're finding the place that thrives and fuels their work. So that's what I would encourage you all to do, is to see yourself and find the place and the context, whether it's at the micro scale that you want to focus on, and people and animals, or whether it's in the bioregions and watersheds and ecological context, or whether for you it's always up in the planetary or climatic, moving between scales and finding the kind of context that embeds us in our living systems is part of the job of all of us. And for me, partly because of the word eco, I still find such power in thinking about Ecohealth as a context of a way to learn about health in the context of the living systems we depend on. So those are some of my thoughts. Thanks for the opportunity to share, and I'm looking forward to some other discussion.
Thank you very much. There's Margot showing us that, actually she's quite familiar with all the spaces. And it's a question of what you are looking at any one time and seeing what strength you can draw from each of these tenets. So let's hear from Karen. I hope she can come up now. You are still muted. She's muted. Is she able to unmute herself?
I'm trying very hard. Wait a minute. Yes.
We can hear you now.
Can you hear me okay?
Yeah.
Yes.
Oh, thank goodness for this. Moses, first of all, congratulations to you and the African chapter for pulling together this extraordinary conference. I have been watching your growth and your contribution over the last couple of years, my friend, and I could not be more proud of you. So thank you so much for continuing on this tremendous tradition of Ecohealth. And it's one that I feel like I have grown up in and found a wonderful home in. And I'm so pleased to see the evolution and engagement in the principles that underpin Ecohealth, One Health and Planetary Health so well by a new group of scholars. One of the things that I've been able to do since leaving the presidency is start to think about how can we take these Ecohealth principles into the economics of global health and well-being. And we have now set up a number of different businesses and business structures where we're negotiating free trade agreements with the European Union and a wide range of Indigenous entrepreneurs around the world. And the kinds of things that we are doing is setting up rules and regulations that will heal our economy and uncouple economies from ecological destruction. So we've set up, for example, in an Australian context, Indigenous eco wholesales, which will have a whole range of business-to-business opportunities. We'll be privileging the wealth creation opportunities for Indigenous women because we look after the botanics in an Australian context. And what we're doing now is making sure that our supply chains will no longer have within them single-use plastics, for example. And so we've gone through and set up a whole range of regulations and opportunities for craftsmen, for small land lot producers to engage in a global economy, but without having to compromise the ecology or environments in which we're working and farming in order for that to happen. The other thing that I did was purchase a farm because I really wanted to put my principles of Ecohealth and One Health into operation. I've bought into a place which is a conservation area and a rural zone, and I'm really pleased to be a custodian of that kind of landmass now and to really recognise and the biodiversity of those of the place in which I'm now a custodian and really helping to revitalise what has been degraded land. And I would never have had the kind of opportunities that I'm now exhibiting outside of an academic context in economies, both small and larger scale, without having a deep grounding in Ecohealth and One Health. And those two disciplinary bases, as well as the philosophy of planetary health, has really helped to enhance my land management skills and my care for country principles. And what I'm doing now is generating a local ecology and economy which is uncoupled from environmental degradation. And if we can really start to manifest ways of being able to produce food, to create homes and shelter for our animals, if we can create social and emotional well-being in the context of land and country, that for me will be really powerful. I also think that what we've got is the chance to really think about our future going forward to 2030 and what the next 12 years will really look like. And in terms of that, thinking through then what we need to do in our own lived experiences to change our set of circumstances, to change what it is that we value, is a mindset change. And we're really, really excited about doing that in Australia through Indigenous-led economies, which will heal all of the supply chains and at least eradicate single-use plastics where we can. So they're commitments of ours. The other part of being an Indigenous entrepreneur that I quite enjoy is really thinking about how we can privilege culture and well-being. So for me, my ancestral connections are through to the Miriam people from Murray Island and the Torres Straits. We were the group of people that disrupted the colonial processes in Australia by recognising that we did have continual connection to country. And for us to be able to manifest that now in political movements, in social movements, in ecological movements, and in agricultural movements is something that we're really moving toward. So I am blessed to have participated in this disciplinary background. It's not been the place where I have stayed, but I have taken those lessons into different elements of my life. And they are both personal. Now as the grandmother of beautiful little grandchildren, growing them up in nature and environments that they can thrive and flourish and contribute to, as well as into the economies that govern how we live and work in different places and spaces. has been very, very powerful. So no matter whether we focus on One Health, Ecohealth or planetary health, those disciplinary and philosophic traditions can be moved into different practices and processes that can benefit humankind as well as all of the animals that we co-inhabit this beautiful planet with. And I'm really, really delighted to be here with all of you thinking about these things deeply and profoundly. And once again, congratulations, Moses, and everyone who pulled together to make this conference a reality.
Thank you, Kerry. Your passion can be felt in this room. It's getting warm in here because of your passion. And it's very clear your strong connection with nature, your strong connection with indigenous people, your strong connection for justice. It's very clear that you'd like to, it's an issue of what you can get from each of those three disciplinaries and make sure that it's good for humans and it's good for sustaining planet Earth. I want to do one thing. I prepared one slide, but I didn't want to preempt what my esteemed past directors were going to do. But I just want it to be shared as we get into the Q&A. I hope we've got the right one. I'll tell you as are you able to put it on slideshow? Can they see it? Panelists, can you see that slide? Panelists, can you see that slide that is there which says panel discussions?
We could see the panel discussion slide, the first one, but not the second slide with, I think, the questions. That's it.
You can see it now.
We can.
Okay. Can you click one more time? Let's see. No.
We can see the listing of these three organizations. Is that what you were meaning?
Okay, somehow the slides must have been distorted there. Right. That's what I want to show. Okay, so what I just wanted to show is that I've got One Health, Ecohealth, and planetary health defined there. The question of whether it's the correct definition or not is something else. But what you see in yellow, it talks about attaining optimal health for people, animals, and our environment for One Health. For Ecohealth, there's an issue of striving for sustainable health of people, wildlife, and ecosystems. And for planetary health, there's an issue of understanding and addressing global environmental change and its health impacts. Can you click again? What you see there is, in those definitions, there's a combination of environment, people or animals, and health. Are you able to click again? So what I came up with, just to be provocative, is that different funders, different approaches to reach a shared goal. What I could pick is that whatever approach we are taking, our goal from listening to our panelists is the same goal, that we want the Earth to have a sustainable planet. So with that, I just want to, you can remove the slide. I would like us to quickly get into the Q&A session. We have gone in 25 minutes into our discussion. So you can remove that so that we can see our panelists. Okay, I'm back with you panelists, and I would like to ask the room here and the platform to react. So somebody should be checking on people who are on Zoom. If they've got questions, we want to give them priority. Can I have some questions? And please tell us to whom the question is directed. If it's just one you are throwing to everyone, it's still fine. Then we'll find out who's going to respond. Yes, Prof. Mafongoya. For the benefit of the panelists, you could just introduce yourself and tell them your background, just so that they know where you're coming from.
Well, my name is Mafongoya. I'm a South Africa Research Chair at the University of KwaZulu-Natal, Agronomy and Rural Development. I'm a plant scientist, soil scientist. I hear a lot of animal people health. I don't hear a lot of plant health. Is it subsumed somewhere else?
Thank you. Another question? I think this first one is directed to all the panelists. Anyone else who has got a question, please raise your hand. Don't let them get away with it. Yes, there's a hand here. Someone keep checking on the platform as well.
Well, my name is Owen. I also want to add what the professors just said. I'm an ecological, I don't know how to call myself, but microbial ecologist. I do not hear a lot of those friends I love. We call them microbes.
Okay, Owen talking about microbes. Anyone else? We have another hand up somewhere. Okay, while people are gathering momentum, let's go back to the panel. Anyone who wants to talk about, it looks like the discussion that went on, it wasn't very apparent that plants were coming out. It also doesn't seem to have talked about some microbes. Who would like to tackle it first? You can come up, anyone? Yes, Pierre.
I'll jump in. Thank you for those two questions. I think they're important ones. I agree that sometimes it may not be clear that plant health is important, and it may not be clear from a focus on human health or animal health that microbial communities and microbial ecology underlies so much of what we see on this beautiful band of green and living system that we have on this planet. So I think, but to see that one or other of these three fields, if you like, don't address these, I think is probably a trivial point, because I think in the fullness of their consideration, of course they would. It would make no sense for us as ecological thinkers who are concerned about human health to not take into account where plant communities are disadvantaged by our activities, and because our plants are part of our surroundings, and our surroundings are part of our lives. And I think that those sorts of and the importance of microbial ecology is paramount, I think, and becoming more and more so in terms of our understanding of the importance of microbiomes. So it may not be apparent, but I think it's a trivial thing, because I think it needs to be there.
Thank you very much. Yes, go on. Margot?
Yeah, I'm really glad that it is sometimes necessary to speak more fully, I think, in agreeing with what Pierre said. I think it's implicit if we really focus on living systems and what creates life. And we do know that microbial ecologies and plants and the deep relationships are, if we do pay attention to any context in an ecological way, we have to pay attention to those things. So it is good to draw them to the fore. But I think part of our skill as, in my opinion, one of the strengths of a nested ecological way of thinking, and it's one of the reasons I put up that slide, but it's never everything in one image.
Thank you, Margot.
But one of the skills is that zooming in and zooming out. Did I cut off? Can you hear me again? Yeah, I'll just wrap up by saying one of our skills is to zoom in and zoom out into understanding context in a really meaningful way. So absolutely, microbial ecologies, soil ecologies, plants, and relationships between as the foundation for any of these living systems needs to be part of understanding context. And I think sometimes we forget that it's this close attention to the specific places at different scales that give us that rich understanding. So yeah, it's good to bring it to the fore, good to foster curiosity if people don't see those connections, good to deepen our commitment to really genuinely understanding context in a really and what is creating life and health in the context we're working.
Thank you for those insights, Margot. Yes, Jakob, going.
Yes.
Please, yes.
Can you hear me?
Yes.
Okay. So thank you for the question about plant health. Indeed, this was not in the forefront at the beginning, but by joining with the CABI, the Center for Agriculture and Biology International, which is an agricultural and plant health organization, we have formally really related to the plant health. And we are developing the inclusion or the much more stronger contribution of plant health. I give you one example. In Uganda and Sierra Leone, we have clinics where women can walk in with their children for childcare, and they can also bring along their sick plants, and they can get phytopathological advice on how to improve the plant health in their home gardens. So these are examples of integrated services that create an incremental benefit compared to working alone. But I must tell you that the plant health people are not so happy. They don't see very much how they should contribute to One Health or Ecohealth. But I think we will get them on board. And another point is about the microbes. I mean, microbes are totally included in Ecohealth and One Health. I mean, we are working on the animal-human transmission of rabies, of brucellosis. So the bacterial side is totally included, and especially with the antimicrobial resistance work, which must be studied systemically between humans, animals, and the environment. The microbes are very well part and parcel of Ecohealth and One Health. Thank you very much.
Thank you so much, Jakob. Karen, do you want to add?
I will try to speak. Can you hear me okay?
Yeah.
Yeah, very good. One of the papers that we wrote recently was around decolonizing, molecular decolonization, I should say, and it was written by a group of Indigenous scholars who were looking to put forward a microcosm perspective of planetary health. So really kind of invested in the different Indigenous perspectives around microbial communities and what it means to be a custodian of microbial communities. And that was a really interesting exercise to go through from different people in different places across the planet, thinking about what the microbial health and well-being of our environments are, what that means then for our internal microbial health and well-being, and then when we do microbial transmission, particularly through maternal and child health transmissions, and thinking about then how we can embrace those concepts of country. And so in terms of the work that we've done with other scholars thinking through what it means to be a custodian of microbial communities, that has been at the forefront of Indigenous political affairs in Australia, because we will be custodians of 52% of the lands and oceans by 2030, which means that we are actually custodians of 52% of the complete microbial biota that makes up the Australian nation. So really giving those microbial entities nationhood status has been really, really powerful for us to be able to do. With the plant economies, what we're really starting to invest in is native botanics that are specific to place, that have co-evolved over 80,000 years with First Nations peoples on this continent. And we are starting to really interrogate, for example, why are non-Indigenous peoples benefiting from crops and from animals that have co-evolved with us and been managed by First Nations peoples for over 80,000 years. And a really good example of that is the kangaroo industry, particularly with exports. And we're finding that there are such incredible connections between microbial health and well-being and the opportunity to participate in global economies for First Nations peoples that have been underutilised and not really found a place in the academic structures of planetary health, One Health and Ecohealth. But certainly when you apply those academic principles and philosophies into other elements of what it means to live a good life, we're finding some really extraordinary synergies, and we're just delighted that you've raised the issue of microbial health and well-being, and then what that means for plant health and well-being. These are incredibly important for Indigenous peoples around the world, and there is certainly a big movement to resurrect and to reimagine what rewilding can look like from those two perspectives. Thank you so much.
Thank you, Kerry, and Professor Mafumboya and Dr. Rubaba. You can hear that there's a convergence on the importance of the aspects that you have raised. Do we have any questions? I have a question while we are thinking of other questions, but do we have someone on the platform who has got a question? Is someone checking? Is there a question? Okay, there doesn't seem to be, but there were some comments there. I just want to put one of kind of a challenging question to my panelists here and say, would we say that we are going the way of churches nowadays? Is it a way also? The sequence we saw, it is very clear. Initially, we had Ecohealth, One Health came along, and planetary health is kind of a new kid on the block. Is it about the fashion? That the latest fashion is the better one? When I refer to churches, is it about the funding framework that determines where one is? Are we being divided by funding frameworks, or are we being divided by what we believe in? Throwing it to you as part of this. Yes, you can start, Margot.
Did my laugh bring me forward first? That was dangerous. It's a great question, Moses. I mean, I think the tyranny of small differences can be such a barrier towards collective action. And I'd make a couple of observations from our the earth embracing conversation that we had, fueled by our early career colleagues, to sort of ask the question, how could we create a moment, although some people can't gather in Durban for this conference, but to bring voices together in a different way, to be in conversation with each other, rather than be focusing on difference, and to figure out where those synergies are. I think I'd just like to reinforce, I think it's wonderful for people to identify the things that really feel the most important for them. I see an enormous vibrancy emerging from both One Health and Planetary Health. And I also saw, particularly in this earth embracing conversation we had, moving across 10 different areas across the 5 different regions of the planet, that people really were still very motivated by the sets of principles that Ecohealth offered them, and that there was things they were finding in Ecohealth they weren't finding in those other places. So what I feel is so important is an effort towards conversation, towards connection, to be finding confluences, to be allowing diversity. I remember, I'm going to refer to our elder and wise guide, Valerie Brown, letting 1,000 flowers bloom can at times, in terms of cross-fertilization, in terms of vibrant diversity, applying that same thinking about what allows emergence. I mean, we're talking about ecology, what allows emergence, what allows things to come that wouldn't have come before. And yet at the same time, where do we find a sense of home and care? And how do we fuel ourselves to do this hard work? Because doing this integrative work is challenging. And for some people, it is actually quite helpful. I struggle a little bit to use the church metaphor, but people find their comfort and their fuel and their motivations by gathering with communities that are invigorating to them. And I consistently, I have found those invigorating conversations across all 3 One Health, Ecohealth, and Planetary Health communities. I have a particular fondness and a commitment to the variation of that is fueled by Ecohealth. And that's partly to do with its heritage. I think it benefits from several cycles and decades of work that has allowed really integrative and meaningful and connected principles to emerge. But I also can see some really a lot of value from the cross-fertilization. So Moses, I think I'm acknowledging that your metaphor could be relevant. I struggle a little bit with it because I think it can put us in a point. It does raise necessary questions of power and influence and funding, and I think those are appropriate things to bring to the table. And I'm interested in the things that enable connections and conversation and emergence. So I'll hand over to Jakob with his hand up there.
I like your use of the word, finding a comfort zone. And as you traversed throughout the world, I listened to some of the sessions, for instance, in South America and North America. And when you moved to Burma, people were talking not as One Health or Ecohealth or Planetary Health. They were talking about issues. And so I do agree with you that sometimes you want a sense of belonging, you go somewhere, but what you are addressing is essentially the same. Let me move on to Jakob.
You can hear me?
Yes.
Yeah. As I am married to a church minister, I'm since 40 years in the dialogue between science and religion. And of course, there is a very important comparison to, for example, the reform in the 16th centuries of the church. And actually, this helps me very much in our struggle today, because also in those days, there were many comparing and diverging streams of thinking. And I think the big paradigm shift that we are making now is going away of reductionist disciplinary thinking towards systemic integrated thinking. And there, Ecohealth, One Health are clearly at the forefront. And Of course, we disagree now, but you will see in 10, 20 years, this will condense and probably converge to some streams that are sustained. We don't know yet which one will be sustained, but that we have to go in the direction that Kerry and Margot mentioned, that is obvious, and we have to go in that direction. And so for me, comparing our current situation with the reform of the church in the 16th century is for me very helpful, because it makes me patient. We have to be patient with each other. We don't have to fight each other. We don't have to kill each other. But I am still against relativism. I think we have to have the intellectual debate. We cannot put everything in the same basket. I agree with we must contextualize. So in every situation we work, we must adapt to the local knowledge, to the local situation. But I give you one example. Working with Maya communities in Guatemala showed us that the concept of zoonotic disease is not existent in Maya medicine. The notion that diseases could be transmitted between animals and humans does not exist as such. And so we have to maintain that deep dialogue of possible inter-epistemic understanding, but it must be contextualized. And if I work also with Tuaregs in North Mali, but a Tuareg epistemology and a Maya epistemology are miles away and hardly to bring together. What I say is, we don't want to relativize, but we want to go into the deep local context and involve the local communities, the authorities, and the scientists. But to conclude, I mean, we are still scientists, and we have to stick to hardcore intellectual debate that is necessary. And to find money for funding, we must come up with verifiable hypotheses that can be compared with integrated transdisciplinary approaches, including local epistemologies. But we must go that way. And I don't see another way around that. Thank you very much.
Thank you very much for encouraging people to go on a path of intellectual discourse. Do we have any other question in the room here? We've gone like 48 minutes, so we still have a bit of time. As I said, in the end, I will ask the panelists to go around and give us their last thoughts, but I'm still with you in the room. Is there anyone on the platform, Zoom platform, who has got a question? There doesn't seem to be any in the room here.
Yes.
Yes.
Now, in terms of academia, where does this resonate in terms of a whole? Because it's kind of transdisciplinary. So when you talk about people teaching animal health, plant health, soil health, people health, how do we sort of find an institution?
Put your mic close to you.
How do we find an institutional home for this concept?
Okay, Professor Mafungoya there posing a question that, when you talk of transdisciplinarity, where can we place the home? Where can we say is the home for perhaps teaching or pushing that field? Do I quote you correct? Yeah. Any other question? Yes, I see a hand up there.
Right, my name is Emmanuel. Yes, I'm from UKZN with CIDERO. Right, mine is not really a question, but I want to share some perspective I share with Professor Margot and the others. We've heard of One Health, Ecohealth, planetary health. Then we also have global health. Now, when we look at all these, as we were saying, it might look like there is some kind of competing interest. But I think we should rather focus on embracing the diversity that they bring, then also harnessing the synergy that they bring. Because these are all different thoughts or thinking. And we shouldn't see them as one being superior than the other. But as we embrace them, probably we could coin an overarching concept like total health, which will be all embracing. So total health, whether it is animal health, whether it is plant health, it is the total health. And human beings become the center of this. It is when we be able to do this, then we can even factor in the spiritual health, which we've not had over here. Prof was going into religion, but I think it's also very, very important. Now we realize that spiritual care providers are playing a very key role in palliative care and also in human health. So talking about all these terminologies and concepts, it is very important that we see an overarching concept that will embrace all these, so that one does not stand in isolation, thinking that there is a progression. Today, we are talking about Ecohealth. Next time, it is One Health, and it is that kind of progression. But at the end of the day, we embrace all these together, then we carry it along to achieve the overarching goal, which is the total health of humanity.
Bring us back actually to the emphasis of this session, which is about synergy, rather than being divided by artificial boundaries. So that's what I hear from you, that we are all working for a common cause, and combined with what we had earlier on, it's an issue of intellectual debate, intellectual research, so that we can achieve what seems to be all of us, a common goal. Any other question? I have not forgotten about yours, Prof. Mafongoya. What I'm going to do is, when they give their way forward, I'll ask them to address that point of where is the home. So I haven't forgotten about you. Do we have any other question? I'm left with some 8 minutes and I want to wrap up. Okay, no one will say, oh yes, we've got one here. Was there another hand somewhere there? Yes. Nombulelo has got a hand up there.
I just want to comment on the comments you just had on total health. I don't know. I don't think that the point of having the different components of health serves to divide anybody, but we also do still have to have subheadings to the health. Otherwise, if you just talk about total health, you may find yourself talking about everything in one and then end up not talking about anything. We are focused on overall health, but in your line of expertise. Like as a biokineticist, I'm a health practitioner, I can't talk about plant health, it's not in line with my expertise. But when I'm talking about the prevention of diseases in my field of expertise, without touching up on animals and plants, I'm not separating myself from that. If you ask me to talk about it in totality, I'll be lost as to how do I transition within these other sectors. I'm trying to think about if we have a subject called total health, and I had to have to do a science, a PhD on total health, where would I really fit myself in? I will end up just talking about the prevention of diseases.
Thank you, Nombulelo. I must say, in my new job, I've learned something. Know something about everything, but know everything about something. I think that's what you're saying there, that we need to go deep. Let me go back I'll come back to you, but I see a hand up is that an old hand, Jakob, or is it a new hand?
Well, I would have been able to respond to the lady's proposal.
Yes.
Do you want me?
Go ahead, please.
Okay. So thank you for that question, and that is very pertinent. And I'm totally against relativism and putting everything in one basket. I can be very clear about One Health. One Health tries to prove an incremental benefit of life saved or financial savings or sustainable environmental services that result from a closer cooperation between human and animal health and other disciplines. And we quantify these benefits. And you know, doctors and veterinarians could work each in their corner and make animals healthy and humans healthy. But if they work together, they must make more animals and humans healthy. And for this, we have evidence. And this is the evidence that we have to produce. And that is not relativistic. That is very hands-on and shows government where they can save money if they work together. So this is the way we have to go.
Thank you, Jakob. Let's say the last question. There was a question somewhere here. Yes, go ahead.
Yeah, so I just wanted to add to Prof's question on the institutional home, like where's the institutional home for all this. So I wanted to check if, let's say, for the early career individuals, or even like the youth, in terms of everything that we have, is there any other form of access beyond, let's say, this conference and maybe other meetings? Like, is there some other home or place where people can be allowed to grow and learn and, you know, maybe contribute a bit more than, let's say, just in conference?
Okay, that's I think your question is where does the early career, focus themselves and which trajectory they must take? Is that right? Okay, Owen, is that another question? No, sorry, the mic is there.
I don't.
Were you holding the mic because you wanted to speak?
Yeah, I wanted to say there is.
Yes, give him back the mic, please.
I wanted to say that Pierre's head has been going up and down for.
Okay. Okay, let's go back to somebody's noticing you here. Can we hear what you have to say?
I'd like to thank you, Moses, and thank you, professors and audience. I'd like to address the home of the home of this type of work and transdisciplinarity together. And my comment is that we don't know. I think that the solutions can come from many disciplines. I think that the exploring animal health and human health, the veterinary sciences, the medical sciences, and so on, I don't think is transdisciplinary science. I think how to
Go ahead. I think we can't hear you now.
Okay, you can hear me now? Okay.
Yes, we can hear you.
I think we need to differentiate between multidisciplinary approaches and transdisciplinary approaches. I think too often we try to find a home for these places in established disciplines. And I think we have to recognize, in line with what others have said, and particularly what Jakob said about the effort that is going to be required and the time that's going to take. We don't really know where the solutions are going to come from and which disciplines are going to be important for the resolution of some of the very, very complex issues that we have facing the sustainability of the planet. So sustainability can really reside in many disciplines. I know that that's not a comfortable feeling for some people, but I think we have to become comfortable. And I'll give you one example. The example is about the emotions that we need when we're dealing with these sorts of things. Previously, you talked about we be optimistic about the trends that we're seeing? And I do think that we can be optimistic, but I also think that we have to accept and acknowledge and not run from the sadness, the grief, the loss, the disappointment that comes with what we're seeing in terms of some of these the disease-related issues or natural disasters and so on. I think we have to not seek to reconcile optimism and hope. I think what we have to do is to recognize that there are multiple emotions. So if we want to explore the emotional nature of, and I think this gets back to the point that about the audience member who talked about spiritual health, we have to find a way of making sure that those other types of knowledges are just as acknowledged in the way that we're seeking to address some of these very big challenges that we have at the moment, and to go with them. I, like you, Jacob, I find comfort in the fact that that we're working towards things that are very, very complex, and to recognize them as complex, to be adaptable in our approaches, and not to shut the door by putting them in one home. Thank you.
Thank you so much, colleagues. Bear with me because we are 1 minute past the hour, and I don't want to abuse our panelists. They are in different time zones as well. What I'm going to do now is to ask them, with their indulgence that we are overrunning our time, to just in 2 minutes or 1.5 minutes, tell us their final word with regards going forward in terms of having in mind these 3 areas, which are One Health, Ecohealth, and planetary health. How should we work going forward? Margot, I put you on the spot.
Eyebrows raised. First of all, the importance of the raising questions and having the curiosity that we've just heard in your audience today. We really appreciate the questions as well as this forum, Moses, and your courage to talk about working together. I want to underscore 2 main things. One is that this is an old idea that we need to keep coming back to, which is that given the current challenges that we have, and that adage that we cannot solve the challenges we have with the same thinking that created them, I'm really committed to this idea of not just doing the same things better, not just trying only harder at the things we've already done. So not just doing the same things better, but doing better things. And I think that those better things are going to arise from the relationships between things. We've spent too long disconnecting things, disaggregating things, separating things out into disciplines and silos and different kinds of knowledges. And transdisciplinarity is one pathway in. It's the word trans, it means beyond discipline. So what is it that we can do when we go beyond the constraints of individual disciplines? We do deeply contextual, ecologically informed work that understands that we need to care for the living systems we depend on, and how do we work together to do that better? And I feel that we can find ways to work together under all of these different monikers. But for me, that core principle is that we have to look at the relationships between things so that we can allow new things to emerge that we haven't yet done, because our existing thinking has been harmful and it has been damaging and has been disconnecting. And so the alternative to that is care and connections and work that does that in a contextual way, relevant to local contexts and right up to the global. So my challenge to you, don't just do the same things better, do better things. I'll hand back to you, Moses, and thanks to you for the ways in which you're doing exactly that.
Thank you very much. Can I come to you, Pierre? Your final words.
Thank you, Moses, and thank you, everyone, for this session. I'm greatly inspired by my other colleagues and their contributions, and to the questions. I appreciate them enormously. My my suggestion is that we look to the arts and we look to music, to dance. We look to, as much as we look to science, and we look to literature, and we look to our emotions as much as we do to our cognitive processes, and we seek to change the way we think by doing things, as Margot says, differently. And they allow us to be aware. They allow us to be more aware of our complex systems and the need to be adaptive in our approaches. And above all, they allow us to care for the future.
Thank you so much, Pierre, for those final words. Jakob?
Well, I think altogether we are quite together, and I think there are some nuances, but I would like to insist on that we have to continue in a systemic way. We have to overcome the contemporary reductionist science. We have to bring the different disciplines together, but in an intellectual way, without relativization. And we have to be transdisciplinary. Our understanding of transdisciplinary is that we bring academic and non-academic actors together. Scientists have to engage with communities and authorities and tap in their practical knowledge, in their own knowledge, and combine academic knowledge and practical knowledge towards a transformational knowledge for societal problem solving. I put in a course, and I can also add a reference to an OECD document on transdisciplinary approaches for societal problem solving. This is the way to go for us. Thank you very much.
Thank you, Jakob. We have lost Kerry, so I'll just try to do a wrap up now. What I've just heard, well, a fantastic discussion, both from the panelists and from the room here. Very good questions coming up and good answers coming up. And we hear common words here. Do things better. And I think that's clearly coming from Margot. And Pierre, still on Margot, she talks about, you know, the idea of transcending into other disciplines. And Pierre comes up with the same words, that we should do things differently. Forget about what we've done things in the past. We must do things differently for good change. He talks about, you know, looking at arts, looking at music. And Jakob is coming back with the issue of, you know, intellectual engagement, and is talking about refining the issue of transdisciplinarity, that it can't be truly transdisciplinary if it's just a group of academics. You need to bring non-academics to connect with them so that you can have good solutions. So with this, really, I really would like to thank our panelists and apologize that I've overrun this session by 9 minutes. But they really rose up to my expectations, that bringing 4 people who have been, you know, in different spaces in the past 2 decades, coming back and giving us insights in the direction in which we want to go. We will definitely, at the end of this conference, try to tease these discussions that have ensued and write them up so that we can inform, you know, the field going forward. And it's very clear that it's about working together for a common goal. So I still go back to what I said when I tried to challenge about religion. There are different religions, but the goal is the same. We are all praying for better things in our lives. And so for whether it's Ecohealth, it's One Health, it's planetary health, the goal that we always converge on is to have the theme of this conference upheld, which is having a healthy community, and that community involves plants, microbes, people, animals, and have justice prevail and be able to live in this planet Earth in a sustainable manner that allows the next generation to enjoy better what we are enjoying today. Thank you very much. I will close this session here.
Goodbye.
Oh, yes.
Thanks, everyone. Bye.
Marco, I
Thank
promise
you.
to be a sister.
Bye-bye, Moses, and all together.
Thanks, Moses. Thanks,
Bye.
Jakob. Thanks,
Goodbye,
Pierre.
Margot. Goodbye, Pierre.
Nice to see you. Bye.
We'll wait to hear to those who are running the program. Is this time for our lunch? Tafazwa, are you in the room? Someone who has got the program so that I can just be able to.
30 more minutes.
Sorry?
We have 30 minutes before lunch.
We have 30 minutes before lunch. Oh, it's lunchtime. Okay. Okay, so that's fine. We don't have another program coming in right now, so it's 12:30. So we will be back here at 1:30. Thank you very much for the engagement, and I look forward to see you back. We will be going into breakaway rooms. Those that are on the Zoom platform, within the lunch hour, you will receive the links to the different meetings, so you can join the meeting that you would like to get to. So for the people who are in here, the others will remain in here, the others will go to the other breakaway room. Thank you very much and enjoy your lunch.
Good afternoon, colleagues. We're back. Lunch was good. I'm not sure about our virtual presenters, but this side, I can assure you lunch was great. We are going to start with this session, which is going to be between now and at least 3. But our first presenter is, I hope you are there and you will forgive me with the pronunciation of your name. Our presenter is going to be Pisarai Ndarukwa. I think she's from Zimbabwe, because the title of the presentation is Assessment of Levels of Asthma Control Among Adult Patients with Asthma at Chitungwinzwa Central Hospital, Zimbabwe. Please help me to welcome Pisarai Ndarukwa. Pisarai, you are virtual, but we are with you here.
Thank you. Thank you. Greetings to everyone in Durban. Okay, so allow me to introduce the subject of my study, which is assessment of levels of asthma control among adult patients at Chitungwinzwa Central Hospital, Zimbabwe, a study which I conducted myself and Professor Chimbari, as well as Professor Sibanda. So rather, this is my credentials. I'm a lecturer at Bindura University and a public health research specialist at, in the Ministry of Health and Child Care. And due to this, I also have a clinic that I manage, which deals with asthma and allergies. So I'll just introduce the subject, where I'm saying asthma control is the extent to which numerous clinical presentations of asthma are reduced or removed by asthma treatment. The control of asthma ensures that patients with asthma live their daily lives as healthy people do. To achieve good control of asthma, the treatment should result in day and night symptoms less than 4 times per week, improve performance of daily activities, and reduce asthma attacks, and that reliever treatment be less than 4 times per week. The treatment of asthma should include the use of controller and quick relievers. The glucocorticosteroids and beta agonists and anti-leukotrienes are the commonly recommended medications for asthma patients. Lifestyle changes, such as the need for daily medication, stopping habits of smoking, identifying and avoiding triggers, as well as the regular physical exercise, are necessary to achieve asthma control. Asthma control level should give an insight to quality of care rendered to the asthma patients. One assessment tool that is widely used to ascertain the level of asthma control is the asthma control questionnaire developed to assess the effectiveness in quality management of asthma. The ACQ has undergone a rigorous validation process and has been standardized and validated in a number of settings and was adopted for this start. The ACQ has been shown to be valid for measuring asthma control, although there has been studies assessing levels of asthma control elsewhere. There has been no documented studies on levels of asthma control for Zimbabwe. Hence, therefore, this study assessed the levels of asthma control among patients, adult patients attended to at Tunguza Central Hospital using the ACQ. The methods which were employed for this study, we used a descriptive cross-sectional survey using an ACQ as a tool for data collection. We also performed spirometry to measure the forced expiratory vital at 1 second as an objective measure of asthma control. The spirometry was done by a trained, hello?
Excuse me? Okay, now we've got your slides. We were worried we're not seeing the slides.
Oh, okay.
Now we've saw the first one, yeah. Okay,
yeah.
Good.
So the spirometry was done by a trained instructor on all the 400 patients with physician diagnosed, asthma. A sample size of 384 was determined for this study, and this was adjusted 400 to cater for large volumes of patients who were. You are not seeing.
Now we see you, but we don't see your presentation.
Let me try to share again.
Please do.
I don't know if you are able to see now.
Yes, we can see the slides.
Okay. So
seeing is the methods. Are you in methods already?
These are methods, yes. That's where I am.
Okay.
Yeah. So nurses interviewed all the 400 physician diagnosed asthma patients, and approval for this study was done through the Medical Research Council of Zimbabwe and the Biomedical Research Ethics Committee at UKZN. And the trained nurses administered the ACQ to all physician diagnosed asthma patients. And the ACQ had 7 questions, and 6 of them were administered by the trained nurses. The last question for ACQ required spirometry to be performed, and this was done by the trained instructor. We performed spirometry by meeting the following conditions: calibrating the spirometer daily and after change in ambient conditions in accordance with the American Thoracic Society guidelines. All the spirometry were performed from a standing height, and patients took an average of 8 to 11 minutes to produce a minimum of 3 flow volume and flow time curves. The curves were checked for quality by the peak and expression phase by inspecting the presence of an instantaneous start and a rapid rise in expiratory flow. Thus, a flat peak indicates lack of effort at the beginning of the spirometry maneuver. Presence of a smooth continuous downward expression with no evidence of erratic exhalation, cough or glottis closure. Then an expression time of greater or equal to 6 seconds in adults 18 years and above. A plateau on the volume time curve without an abrupt end in the expression phase. The best reading of the 3 acceptable and repeatable efforts calculated as the largest sum of the forced vital capacity and forced expiratory volume at 1 second according to the time of expression was then recorded. Interpretation of the ACQ data. Using the ACQ, we define the minimal important difference into 4 groups. That is group 1 with the controlled asthma, ACQ, which is less or equal to 0.75, and group 2 with mildly uncontrolled asthma, where between 0.75 to and ACQ less or equals to 1.25. Group 3 was the one who was regarded to as having the moderately uncontrolled asthma with the grading of 1.25, which is actually less than the CQ for control, which is 0.5, and greater than or equal to 1.75. And the group 4 with very uncontrolled asthma had an ACQ greater or equal to 1.75. The cutoff points of ACQ of less than 0.5 for controlled asthma in the clinical practice was used to distinguish the well-controlled from uncontrolled asthma. The minimum important difference for the ACQ of 0.5 on the 7-point scale was used as determined in other studies. So the results, these are the demographic characteristics by asthma control status using the clinical practice cutoff point of 0.75, which showed that 152 of the study participants who participated in this study had a controlled asthma compared to those who had an uncontrolled asthma, which is 248, and the median age using was 33 for those that had a controlled asthma, and it was 35 for those with an uncontrolled, asthma. You will notice that there were more females who participated in this study compared to males, and that those that had attained a secondary level of education were actually more than any other group of participants who participated in this study. Those that were married were actually the majority of the study participants in the study, and there were more Pentecostals as well as the Protestants who were likely to have an uncontrolled asthma in the group. And the majority of those not employed were likely to also have an uncontrolled asthma compared to those employed. And there was indeed risk factor of having an uncontrolled asthma amongst those that were living in the urban setting, as well as the peri-urban setting compared to another groups. So a total of, like I said, 400 participants participated in this study. There were significant differences between males and females with controlled asthma. The fact that more females achieved a better control to their asthma can be attributed to their health-seeking behavior, which is better than that of men. This has been shown in studies carried out in South Africa and Nigeria, which has shown similar findings, hence the need to improve asthma awareness amongst men as a paramount activity to achieving good asthma control. The majority who were married in this study and the single were contributing to 9%, to 24%, while 9% and 5.5% were those widowed and divorced respectively. The study showed that more married patients were likely to achieve good asthma control compared to their divorced or widowed counterparts. This may be due to the fact that widowhood and to some extent being divorced erodes social and financial support. Similar to our findings, researchers from India reported that being widowed was associated with more adverse health outcomes for patients with chronic conditions. Our study has shown that being a better control of asthma was among the Pentecostal sect members. This could be as a result of the fact that members of the Pentecostal religion engage in medical pluralism, which allows them to take medications and faith healing. All the 7 ACQ items indicated were actually, significant. The bone fare analysis to distinguish between paired groups using ANOVA showed that all the identified questions 1 to 6 were significantly different. The predicted FEV1 percentage for the mean scores for the controlled asthma group against moderately uncontrolled and very uncontrolled asthma groups were significantly different. The predicted FEV1 for the mean scores for the mildly uncontrolled asthma group against moderately uncontrolled and very uncontrolled asthma groups were significantly different. These results may reflect the need to step up asthma treatment according to level of asthma control if we are to achieve the best asthma control. So these are the comparison of the asthma, ACQ asthma, using the minimum important differences as already pre-alluded in the above slide. The conclusion, although good asthma control can be achieved for most patients, the reality in clinical practice based on this study, it seems to suggest that asthma remains poorly controlled. There is need to improve quality of care to these patients if control of asthma is to be achieved. The use of a CQ may provide the healthcare providers with a good and efficient starting point to actively and timely detect patients with uncontrolled asthma symptoms in the clinical practice. I would want to thank the following organization for funding this work. That is Oak Foundation, the Chiba SA, Professor Chimbare was my mentor. I would also then want to appreciate the Coltech for allowing us to use the asthma control questionnaire in order to collect data for this study. Chitungiza Central Hospital, which was the main start site for providing the, the clinic, the start clinic. Ministry of Health has facilitated actually me attending this conference, and it has booked me in one of the local hotels in Zimbabwe, in Victoria Falls. The University of Bindura University of Science Education, where I'm also employed. They have given me time off to attend to this. The clinic that I manage, which is a specialist clinic found in Zimbabwe at number 72 George Silondeka Avenue in Harare, which provides asthma diagnosis and treatment, as well as phenotyping, also supported me as the presenter as I was coming to Victoria Falls, where I am currently. I would want to thank Professor Chimbare for particularly ensuring that all the registration fees required for us to attend to this workshop has been, realized through his funds. I thank you.
Thank you, Professor. Thank you so much, Professor Daruko. I hope that you are going to stay, because we didn't talk about the issue of giving the floor some time to ask questions. I'm looking forward to you staying a little bit so that at the end of the last person, maybe we give every other person a chance to answer the questions. Are you staying?
I will be staying in order to, yes.
Please do, otherwise we really enjoyed the journey that you took us through in your study on asthma, but I think because of time, I'm just going to go to the next presenter, and then later on, after the third presenter, we will have questions. Please do stay.
Thank you.
Colleagues, let's give him a big clap. He will hear it even if he's up far. Thank you. We're going to move to our next presenter. I am hopeful that he or she is there already awaiting for us, who is presenting on the associated risk factors for contracting rabies in Murewa district, northeastern Zimbabwe. Please let's welcome Margaret Macherera. Yeah. Welcome, Margaret.
Good afternoon.
Hello.
Good afternoon. My name is Enika Chikanya, and I'll be presenting on behalf of Margaret Macherera. Hello, am I audible?
Yes, we can hear you. Please go ahead.
Okay, thank you very much. I'll be presenting on this project that we undertook together with Margaret Macherera and Arthur Mavisa on associated risk factors for contracting rabies in Murewa district, that's in Zimbabwe. So this presentation is going to cover the introduction, the aim, objectives, methods, results, conclusions, and the recommendations that we made. As an introduction, we are saying rabies is a fatal disease which is responsible for many deaths globally around the world. And 99% of all globally reported human cases are due to exposure to dog bites of unvaccinated dogs which are infected by the rabies. And unfortunately, it's fatal. At the onset of clinical symptoms, there is no reverse. One can die. Of note is the fact that jackals initiate rabies outbreaks through biting dogs which are unvaccinated, thereby infecting them with the rabies virus. So narrowing down to Zimbabwe, according to a report made in 2016, at least 16 cases of rabies deaths are reported annually. And in Zimbabwe, the jackal is considered one of the most reservoir hosts for the rhabdovirus. And then further narrowing down to Muriwa district, which was the study area, it is one of the districts which we've experienced rabies outbreaks. So in terms of establishing risk factors which can be associated with contracting rabies, geographical information systems are of importance and can be used. So this particular study was motivated by the fact that there were 4 rabies cases which were reported between January 2017 and July 2018 in Muriwa. That's in 2018. So the aim thereof was to assess risk factors for contracting human rabies in Ward 30 of Muriwa district. The objectives of the study were to assess knowledge regarding rabies, to determine practices which may expose people to rabies, to map dog bite hotspots, to determine the vaccination status of dogs, as well as to determine the spatial distribution of jackals and dogs in relation to the rabies cases. So that is the map of the study area, which I mentioned earlier on. A descriptive cross-sectional survey was the design which was used. And in terms of sampling, the study area, the dog bite cases, and proxy interviewees who were the relatives of the deceased were purposefully sampled. And then in terms of the study area itself, we divided into 6 clusters and we did cluster sampling. And then for the unvaccinated dogs, we had to use snowball sampling, as well as in terms of looking for jackal presence, we also used snowball sampling. So a questionnaire and a data capture form were the tools which were used. The questionnaire was for interviewing the selected participants, and then the data capture form was used to capture GPS coordinates. In addition, we used a GPS handheld device to capture geocodes, that is for jackal presence, for dog bite cases, and for the dogs which are vaccinated and those which are not vaccinated. So in terms of data analysis, there was spatial analysis and statistical analysis. For spatial analysis, GPS coordinates were entered and streamlined in Microsoft Excel, and then the coordinates were exported into Quantum GIS to produce thematic maps. In addition, the buffering technique was used in Quantum GIS as well to map the estimated travel range of jackals. And then point data was interpolated into fields, and all spatial data sets analyzed the way overlaid. We used overlaying techniques for establishing associations. And then the final creation of thematic maps was done using the map composer function. Then moving on to statistical analysis, the collected data was analyzed in EpiInfo 7. And then the Likert scale was used to score knowledge. And then in terms of coming up with the 3 different levels of knowledge, a method adopted from Memo et al. Was used. Chi-square and relative risk were the statistical tests which were also used. Then moving on to the results, those are the general social demographic characteristics of the participants. We initially enrolled 263, and then we managed to locate 195. Then the group of participants was male dominated, as indicated, and also the majority age group there was 12 to 39. The results on the knowledge level revealed that over 74% of the participants had a low level of knowledge regarding rabies. In terms of practices, it was found that 23% of the participants had dogs. They actually owned dogs. And then 24% of the participants had unvaccinated dogs. And then in terms of time taken to seek treatment, we found that the majority of the participants, which is 53% of them, they sought treatment for dog bite management within a week. And then most of the participants indicated that they would seek treatment for dog bites at their nearest health facility. That was 97%, 98% of the participants. In terms of practices associated with exposure to rabies, there was an association which was noted between dog ownership and contracting rabies with a relative risk of 10.95%. It was also found that owners of unvaccinated dogs were more likely to contract rabies, as well as dog ownership and non-vaccination. These practices which were also found to be potential risk factors for contracting rabies. This map is showing dog bite, the mapping of dog bites and the vaccination status of dog bites, of dogs, and also dog bite hotspots. So if you look at the top left map, it's indicating dog bite cases which were mapped. The top right map is indicating dog bite hotspots, which are places where dog bites took place. The bottom left map is showing in green dots the vaccinated dogs which were mapped, and the yellow dots are showing unvaccinated dogs. Then on the right, the bottom right map, it's an indication of unvaccinated dogs with the exclusion of the vaccination of the vaccinated dogs. So for the bottom left map, you can see that there is interaction between unvaccinated dogs and vaccinated dogs, which can cause the transmission of rabies. This is a follow-up to the previous map, which I was just showing. The dog bites, most of them were recorded in the high density cluster, and fewer of the dog bites were located in the low density cluster. Then, in terms of the vaccination status of dogs, as I indicated earlier, there were some spatial overlaps between vaccinated and unvaccinated dogs, which has a great potential for rabies transmission. This is another map which is showing spatial distribution of jackals and the range zone for the jackal. The top left map is indicating mapped spots where jackal presence was witnessed among residents. And the top right map, there is an orange color, which is showing that top right map. That is that's the range zone for jackals, the 12-kilometer range zone for jackals. So the bottom two maps are actually indicating that there is jackal presence. They are actually showing the similar results to the top two maps. So this is a map showing spatial patterns for potential interaction between jackals and vaccinated dogs and dog bites, the dog bite hotspots. So the green circles that you are seeing in that map and the arrows which are pointing therein, they are depicting a spatial overlap between all the aspects which were being studied. That is the dog bite hotspots, the jackal presence, the vaccinated dogs and the unvaccinated dogs. It's all in this map. And it was found that there is an interaction. So from the spatial overlap of dog and jackal distribution shown in the previous map, jackal presence is a risk factor for contracting rabies in Ward 30. So similar studies have shown this as well. In conclusion, it was found that there were low knowledge levels regarding rabies, and dog ownership and non-vaccination of dogs were found to be practices that may expose individuals to rabies. And then residents in a high density area was also found to be a risk factor for contracting rabies. The fourth recommendation was that, the fourth conclusion was that unvaccinated dogs in Ward 30 are a potential risk factor for contracting rabies vis-a-vis distribution of dog bites. And the final concluding point was that spatial overlap of jackal presence and vaccinated dogs and dog bite cases is a risk factor for contracting rabies. Having concluded this, we recommended that there should be a more robust approach in terms of approaching the community to educate them in terms of preventing rabies. The One Health approach was also found to be very useful, so that collaborative efforts can be made use of to make sure that the district is better prepared for such outbreaks in the future, and then so that they can respond accordingly. Intensified regular mass dog vaccination by the vet department in light of jackal presence in the area was also recommended. Right, and also that the dog and jackal potential interactions have to be curtailed in cooperation with the Parks and Wildlife Department. Continuing with the recommendations, We also recommended further studies to analyze dog bite management, rabies outbreak response, outbreak preparedness and response. Feasibility studies on control of rabies in the jackal population were also found necessary, as well as the advanced geospatial statistical and or modeling future patterns of rabies spread risk. We'd like to acknowledge the support of the Ministry of Health here in Zimbabwe and all the stated institutions that were instrumental in helping us to carry out this study. I thank you and over to you.
Thank you. Thank you, Anika. Thank you very much. Again, I would ask that you stay so that after the last one who is following you, have the floor asking you some questions. Please do stay, but we really enjoyed the journey that you took us through. It's scary because we love dogs, but if they are so dangerous to us, we might as well be as scared as I am already now. Colleagues, let's give her another big applause. Okay, our next speaker is very far from where we are, and that's not saying Zimbabwe is too close, but this one is in Canada, and he is Federo Andrade Rivas, and I may just be pronouncing you incorrectly. You will forgive me, I'm an African. I'm going to pronounce this in the way I see it. He is presenting approaches to advancing healthy and sustainable food systems, lessons from the tale while North nations struggle to establish sovereign management of resources. Over to you.
Hello, can you hear me?
Yes, we can.
So no worries about the pronunciation. I did my master's in South Africa actually, and I think I never got one single name right, but people were very warm and always happy to hear me how I pronounce things in South Africa. So I'm very happy to be here. I'm very sad that I'm not actually there in South Africa. This could have been a very good opportunity to go back there. I'm going to be talking about our research project that is in collaboration with the Tsleil-Waututh Nation, that is the first indigenous nation here in Vancouver. And actually Vancouver is located in the traditional and never ceded territory from this indigenous nation. So I'm going to be talking about how industrialization is related with food safety for the Tsleil-Waututh Nation. And tell you more about our marine toxicology research that we conducted, as I said, in collaboration with this indigenous nation. Just the presentation outline, I'm going to go through, talk a little bit about our research program, what were the background and objectives of our research, what methods did we use, and quickly go through the results and discussion. So this collaboration, it's not moving forward. Yeah, there it is. So this research is part of a collaboration with the Tsleil-Waututh Nation that is led and governed by them. So we were actually the indigenous nation contacted a different group of universities and local authorities to conduct this research to investigate the different impacts of environmental pollution on the ancestral harvesting of their Burrard Inlet, which is where the nation and Vancouver, the city of Vancouver, is located. So as part of this study, there has been several papers that have been published looking in integrity at how food systems and health equity are connected in an era of globalization. So this project is part of a larger research program that is done in collaboration between UBC, the University of British Columbia, and Universidad Andina Simón Bolívar in Ecuador. And we are conducting 5 research projects, both in Canada and in Ecuador, to examine pathways to which food sovereignty contributes to health and sustainability, and how this is affected by social and ecological factors. And one of the areas of interest is chemical contamination of food systems. So why are we concerned about this, and particularly about the contamination of traditional food systems, is because traditional food systems, beyond providing high quality nutrients and proteins, they are a source of social cohesion, they strengthen cultural identity, they are connected with physical activity and collective mental health. However, we are concerned that of the potential source of toxic exposures that traditional food may pose. And we know globally that indigenous populations are at higher risk of exposures to pollutants. And this is true both in low, middle, and high income countries. And for example, in Canada, indigenous populations presents the highest gap in disease burden when compared to non-indigenous populations. So they are not doing well here. And there being like very infamous cases of high levels of contamination in many places in Canada. So we were together and we were approved by the Chief and Council of the Tsleil-Waututh Nation. And in this map where Vancouver is located, you can see the area of the traditional territory of the Tsleil-Waututh Nation. And this is an area that has been heavily developed, and there is large industrial activity, a city over 1 million people. And this activity has nearly eliminated safe shellfish harvesting by the Tsleil-Waututh Nation, which is their traditional marine food that they have been accessing for years and years. And recently, there's been this great concern about the expansion of a pipeline that is taking oil from Alberta to the port here in British Columbia. And this expansion of the pipeline will triple the capacity to transport oil and threatens, of course, it will mean that more boats are moving through the inlet, and more potential for pollution. So we definitely, like, this will be threatening Tsleil-Waututh Nation progress to restore harvesting in the area. So this collaboration aimed to assess the levels of heavy metals and pH in 3 species of shellfish at 3 locations in the Borar Inlet, and also to compare these levels with some screening values that were developed by the Tsleil-Waututh Nation. And I will explain a little bit more about that later. So these pictures are showing some of this traditional territory in this area here in Canada. So we look at 3 different study sites, both close to the pipeline terminal and farther up in areas that are being restored for harvesting. And we look at 3 different species that are very important for the community, that they that unfortunately now they have high levels of contamination, and for that reason the harvesting has been reduced, and it's only strictly done during some seasons during the year for rituals and celebrations, but it's not constantly harvested. And this is our species that they want to recover, and they want to start harvesting more and rely more on them. So we took samples in 2020, just before we went into the lockdowns here for COVID. So we're rushing to finish this. And we took like different samples for each site for a grand total of 54 samples, and did the laboratory analysis using a mix of gas chromatography and mass spectrometer. And all the labs were conducted here in Canada. Something that I think that is very relevant is that every time that you measure a level of contamination, either in food or in the environment, like you would like to compare it with certain level or limit, and to know like if you are going above or below that level. So here in Canada, there were some guidelines about the levels of these toxics in the in food. However, these guidelines are created based on an average Canadian, not necessarily on the type of food behaviors and food practices, and also the amount of fish that a community, an indigenous community, would eat or would like to eat in the future. So we decided to compare the chemical levels to screening values that were developed in collaboration between the Tsleil-Waututh Nation and the British Columbia Ministry of Environment. And this is very important because this, through a collaborative process, the Tsleil-Waututh Nation developed these levels based on the type of people that were exposed, the amount of exposure levels, but also, and very importantly, what are the aspirational rates of shellfish and fish that they would like to eat in the future. So instead of just looking at the damage and just looking at how much they're currently eating, because as I mentioned, they have like stopped eating because of the levels of contamination, they decided to create this, screening levels that are aligned with the objective of, at some point, increasing the amount of fish that they're eating. So we found concerning results for some of the chemicals that we were looking at. Here in the y-axis, you can see the concentration in milligrams per kilogram, and then the x-axis, you can see 4 different types of heavy metals. And we look at this in 3 different species, as I mentioned: softshell, varnish, and crab. And something that is important to highlight here is that depending on the limit that you look at, you will draw like different conclusions. And this is important to be very critical from the when we're looking at different limits and to decide what are we comparing against. So you can see in blue, that's the Health Canada maximum permissible level. But then you can see other 3 levels that were developed by the Tsleil-Waututh Nation that are on yellow, green, and red. And these ones take into account different levels of food consumption, and also take into account different populations that will be exposed to them. And in that case, you can see here, for example, when we look at the 3 different sites that we were analyzing, you can see how, depending, and I'm circling those, you can see how, depending on the different limits, you will draw different conclusions. Regardless of this, we did find some concerning levels, especially of arsenic in crab, and some other species for lead, cadmium, and mercury. When we look at the pH, we were concerned to find that there's the mixture of carcinogenic pH was above the limits. But again, it is important to take into account like which screening value or which limit are we comparing against. Interested enough, in one of the areas that has been looked as a potential area for future harvesting, we did find some levels of contamination of heavy metals, but we did not find concerning levels of polycyclic aromatic hydrocarbons. So a bit of a summary of the results. There are concerning levels of chemical contamination in all 3 species, in all sites that we sample. Some of the levels are exceeding the local established screening values, but even also Health Canada maximum permissible levels. Concentrations of lead, mercury, and some of the pHs in clam tissue were higher than those found in previous studies in the region. And we are concerned about the levels of BAP and arsenic that are higher than those that have been reported in the northern area of British Columbia. And we did find that softshell and varnish clams had higher levels of contamination than crab. And this could be related with just behaviors of the species and how do they feed and how much time they spend in different parts of the water. Interestingly, we didn't find any difference in heavy metals levels of contamination across the study sites. We were hoping to find less levels of contamination in areas farther to the pipeline and to heavily industrialized areas, but this was not the case. This may be related with other sources of contamination or just natural sources of these heavy metals. But overall, this is showing us like how the extent of the levels of contamination there in the area. So we did have some limitations. It was obvious, it was a cross-sectional study, so we couldn't see trends in time and the sample size. We would like to do something larger, but of course this is very expensive, and in later stages we are hoping to do that. And we also had issues with the limit of detection. So there were a lot of samples for PAH that were below the limit of detection, and we're just limited by like the available technology to measure some of the contaminants. And of course, in later steps, like the idea is that after this project, there was going to be a complete risk assessment of the current practices of the Tsleil-Waututh Nation, because some people do like still harvest more fish and more marine species, but we don't entirely know what are the risk perceptions and risk behaviors associated with food consumption in the Tsleil-Waututh Nation. But this was put on hold after COVID and other priorities, but we're hoping to get back to that soon. So we definitely need further assessments in the area, and it's very interesting how the conclusions change when you include aspirational consumption rates and do not only focus on the current state. It was very important for us, and I think in this area, like just this connection between ecosystems and health, it was very important that we were using as sentinels for contamination species that are both important for the environment, but also for human health, that they're connected somehow to human health. Why so? Because previously, most of the research looking at contamination of marine environments have been looking at species that are not consumed by humans or have no like a strong relation with humans living in that area. And this approach of looking at this type of a species had been shown to be powerful. It also can means that there is people more involved in changing the situation, and there is more political power to make some changes there. Something that is very concerning is that the pipeline did go through a lot of environmental assessments, but they didn't assess the potential health outcomes of like increasing the capacity of the pipeline and the potential pollution that comes from it. So in any process of development projects, like we're pushing towards including this health outcome. And we also consider that that the levels of contamination have to be monitored and have to be assessed constantly, and this should be done in close collaboration with the Tsleil-Waututh Nation. I cannot express like enough how important it was to collaborate with communities and and have a very strong conversation about what this levels of contamination mean and what are the steps to move forward about this. So it's essential that the levels are not allowed to raise further. It is crucial when available to use these locally and relevant risk-based benchmarks. For example, when I do work in Colombia, the country that I'm from, we most of the times do not have available this kind of guidelines, and we do have to rely on whatever it is out there. But in these cases where there's these resources for locally relevant risk-based benchmarks, that's the ideal situation. We think that this kind of process where indigenous populations are the ones in charge in collaboration with institutions to create these processes are case studies to replicate. So here I'm just as a ending note, I think that this is the big difference between doing damage center versus desire centered research. So sometimes we focus too much on damage, and that's an important area. And this is something that definitely we should keep doing and registering, like the levels of contamination, how much is going wrong. But also when working with indigenous communities and any other population is very important to also understand like where they want to go, what they want to work towards, and what are their objectives. And this basing research on desire, I think that is a better, creates better options for change and for finding opportunities just to make things better. So I just want to thank you, all the team that collaborated in this process, including like indigenous researchers and people from the community, but also researchers from UVC and Simon Fraser University. And here's my email if you want to contact me, and my Twitter. I don't know if Twitter is going to be there for very long, but anyway, please contact me if you have any question. Thank you so much.
Thank you so much, Federico, and good luck in this journey. I can see you are a PhD candidate. I can't wait to welcome you at another conference as Dr. Federico.
Thank you.
Colleagues, hopefully you will stay, and it's a chance for the floor to ask questions if there are any. But before you even ask the questions, you can see that although these three presentations were unrelated, from asthma to rabies to industrialization, they all speak to the theme of this session, which was on health, environment, and diseases. So as you think about your questions, please consider how important it is as part of this Ecohealth and how things really come together and affect how we live. Okay, let's see if there are questions, and please do indicate who the question is or which presentation your question is directed to. Checking on the hands. Yes, there's a hand here, and then there's another one at the end. Who is helping us with the mic? There we go. Thank you.
Thank you. Good afternoon, colleagues. My name is Melele from the Cancer and Infectious Diseases Epidemiology Research Unit at UKZN. So I have questions for Prof. Ndarua and the lady that was presenting on behalf of Margaret Macherera. So for Prof. Ndarua, my first question is, thank you for, first of all, thank you for the demographic profile that you provided of your sample. However, when you were giving your results, I could have possibly missed this, but I didn't see a result on the variable of settings versus asthma control. You did give us feedback on marital status, gender, and religion, but I was curious about your setting in particular because your urban setting, a large percentage of your sample, 68% in fact, came from there. So I was curious to know that. So that's my first question. The second one is in your breakdown of settings, you had urban, peri-urban, rural, and farms. How did you differentiate between rural and farms? And then the next question is for the next presenter. Oh, should I continue?
Give you the name, Anika.
Anika, sorry. Thank you. So Anika, this is for you. You reported that the majority of your samples were between the age group 12 to 39. That was 69.7% of your sample. How, okay, so what were the other blocks or age ranges that you had? I'm not used to, the age range being given in that way. Somebody may say maybe 6 to 18, maybe 18 to 25 or 24 to 39. So could you please explain how this age range distribution came about and what were the others? Thank you.
Thank you. I think we can just give the speakers the time to answer while the mic is roving towards the other person to ask the questions. So it's your chance to respond.
Okay, thank you, Chair. I have two questions that have come from Melari related to the setting and how I differentiated rural and farms. So this study was conducted at a hospital that is indeed in an urban setting, and it is a referral hospital that receive patients from all geographic setting of the country, whether rural, the farms, the peri-urban, and again, also within the urban setting. So this start setting was where I used to work and I used to practice at that hospital, leading to the identification of the problem of interest, which was assessing quality of care, which was the main study. Hence, this is how we come up with the start setting. Differentiation of rural and farms. So if I had an opportunity, I would have shown the categorization of the two, but rather the farms in Zimbabwe is where commercial farming is practiced. And the rural is actually regarded as the reserve. And this is where peasant farming is actually practiced. And their rather main activity within the rural setting is related to their activities of peasant farming and rearing even of animals. And thus a fine distinction between the two is that the farms are specifically the commercial kind of agricultural activities, and the major farms are actually meant to ensure production of food for feeding the nation and for export, as compared to the rural setting. That's the differentiation which resulted in us categorizing someone as being from a rural setting or from a farm. Thank you.
Thank you. There was a question to Enika Shikanya. Enika?
Thank you. So the response is that we had 7 age groups, which were 6 to 11, 12 to 19, 20 to 29, 30 to 39, 40 to 49, 50 to 59, and 60 plus. So the majority age group came out as a combination of 3 age groups, which are 12 to 19, 20 to 29, and 30 to 39, which constituted approximately 70%, as I stated earlier. I hope it answers the question.
Thank you. You answered. The mic was going that direction.
Yes. Good afternoon, everyone. I'm Lemba Samtele from the University of Zambia. My question is going to Anika. I noticed in your presentation you said that there was a high association between owning a dog and acquiring rabies, as well as the number of unvaccinated dogs was quite high. So the question I have is, did you manage to look at what interventions are available locally towards unvaccinated dogs? So for example, in Zambia, if you have a dog that is not vaccinated against rabies, the local authorities are mandated to kill the dog on spot. So do you have such interventions? Thank you.
Okay. You can respond while I look if there was another hand.
Okay, thank you for the question. So in terms of measures for unvaccinated dogs, at the time of the outbreak, the available options were shooting down stray dogs, carrying out a mass vaccination campaign. But unfortunately, at that time, in that specific area, the measure of shooting down stray dogs was not implemented because there were no bylaws. The local authority of that particular area had no bylaws which would empower them to shoot down people's stray dogs. So the response measures there was only centered on awareness creation, mass dog vaccination campaign. And that was all to it during that time. But currently, I hear the local authority that side has since established some bylaws which they are making use of, and I hope part of them permit them to shoot down stray dogs, which is very effective in terms of responding to such outbreaks of rabies. Over to you.
Thank you. Thank you. I'm checking if there's any other hand. Is there another one? Oh, here, there's another hand.
Oh, thank you.
That would be the last one, yeah?
No, my name is Owen. I think mine are not comments as yet, but I just out of curiosity to Anika first. You talked about some having, okay, maybe it was 3% of people who may go to traditional healers for, because I saw it was 97%. Is there any like traditional medicine or herbal treatment for rabies? I mean, or we know that people normally die, but what's the treatment? And then again, I can't pronounce the name for the last speaker. Maybe I missed it. Did you also check the levels of those heavy metals in the soil or water levels? Because I was seeing you were talking about fish or the but I did not see if you checked in the soil. And then a general question, is there like a non-higher level among the population, the indigenous population, levels of higher metal concentration that has been established, which is different from the rest of the population?
Thank you. We will start with Anika.
Okay, thank you for that question. Unfortunately, during the interviews, we did not probe to find out whether there were any available traditional medicines, particularly for rabies. Ours was to just assess the treatment-seeking behavior of the participants. So I do not have a direct answer to say yes, is there or not, because we did not probe that far. I hope it answers you. Thank you.
Thank you. And then we can go to Frederic.
Thank you for the question. Very interesting. So we, at some point, what we would like to do is to have a further risk assessment where we can actually measure in depth how much people are consuming, and then have a better idea of what are the levels of exposure of the population. At this stage, we don't have that information, but going around your answer, like what we think that is very important with this indigenous population is two things. Is the amount of fish that they consume. Like sometimes there's levels, these screening values and limits that are set at the national level are set based on the average national rate of fish consumption. And they don't take into account the amount of fish that these communities are eating, and also potentially they don't go into depth into look like a specific populations as pregnant women or children. And that's one thing. Another thing that happens with indigenous populations is that sometimes these species are not eaten like in small quantities throughout the year, but there's like a big celebrations where they gather and eat like large quantities of these resources. So that's why like there might be some difference of the on how we measure exposure in these indigenous populations. As far as how much do we know that the populations have been affected, like we do know that this nation has reported large levels of and risk for some cancers that have not been explained by other reasons, but like we will have to move forward and doing research about that. I know I went like around your question a little bit, but if you want me to specify about something else, like just let me know.
Great, thank you. There's always that thing about saving the best for last. I chose not to introduce myself, but in case you're wondering, I am Professor Sinego Kuduma from the University of KwaZulu-Natal. I was just allocated to be your chair for this session. And I have just one last announcement. We are about to start our gender session. So I will allow people to go and grab a cup of tea and whatever is there and come back with that so that we start the next session on time. Thank you so much to our presenters. Although they were not here, let's give them a big round of applause. Thank you. So we can go grab our tea and come back and prepare for the next session. From your friend. I saw you in like, where's brain? About mental problems. Yes, yes. Oh, okay. I made information. So you're in no. Looking much. Yeah, I am. That's why I just thought, you know, when you think everybody knows you, but then you start wondering. Because the first thing is, because I wasn't going to ask this, I was going to ask you. Wondering. If someone called up on it, no, I don't even have the accent to the game. So I didn't communicate. So how so? Yeah.
to leave this session after you click on the new link. Start afresh. I'm going to repeat myself 2 or 3 times. Okay, to all the guys that are on Zoom link, please check your chat. There's a new link that is on the chat. You may click on that new link. It will take you to the next session. As this link is no longer will be seen anymore. So click on the new link on your chat. It'll take you straight to the meeting. If anyone on the Zoom, if you can raise your hand, if you have any issues, and then we can see if we can tend to you directly. So once again, there's a new link on your chat. Click on your chat, click on the link, it will take you to the next session. Albert? Too dark on the screen. Too dark on the screen. Hey, my friend is here. Waiting on session here. Musa, did you send an invite? Okay. Nothing arrived yet. So guys, one more time to all the Zoom land. You will be leaving this session and joining the new session which is on your link. Check on your chat. Your chat group will have the new link. If you can just click there, it'll take you to this session that's going to be happening now in the next 5 minutes. I saw one of the ladies. Is there anyone in the room that left a charger?